$453 million. And as of right now, we're forecasting a $33 million overspend, which we'll cover in the different programs on the slides ahead.
As we get into our Medicaid financial review, we thought we would address the 2025 federal government shutdown. Due to the ongoing federal government shutdown, SNAP benefits will not be issued for November of 2025. SNAP EBT cards will continue to work, and previous SNAP balances may be used. Medicaid benefits are not at risk, and TANF benefits are being issued in November. We'll begin a review of our SNAP program. The Supplemental Nutrition Assistance Program, SNAP, provides food assistance to low-income individuals. It's a federal aid program administered by the USDA Food Nutrition Service. The distribution of benefits occurs at the state level. Benefits are provided on an electronic card that is used like a debit card and accepted at most grocery stores. The benefit is currently 100% federally funded. The administration costs are currently split with 50% being funded by the state. And you can see our program metrics for the first quarter of SFY26. We issued, in September, we issued $111 million, like $460,740 in SNAP benefits, and we had 5,771, well, my eyes are bad, so I can't see that. So we had about 572,000 SNAP recipients in September, and our average household issuance was $406.99. And then in comparison, in SFY 2016, we had about 803,000 recipients with an average issuance per household of $273.46. And this shows you the total issuance for the first quarter of SFY 2026 was $335,816,701. We have upcoming SNAP changes to the SNAP program that will impact us fiscally. The SNAP administration share increases to 75% for the state effective 10/1 of 26. This is an estimated fiscal impact for SFY 27 of about $37 million because it is 3 quarters of the state fiscal year. And then the annual estimated financial impact is $50 million. The state share of the SNAP benefit is based on the SNAP payment error rate. So we estimate a fiscal impact between $71.5 million and $214.4 million. It's effective 10/1 of 27 and will be based on the error rate for 25 or 26. So for reference, the SNAP issuance in 2025 was $1.4 billion. And then how it breaks down is there's no cost share if the SNAP error rate is 6% or less. If the error rate is between 6% and 7.99%, the state share is 5%, which is approximately $71.5 million. The error rate between 8% and 9.99%, the state share is 10%, approximately $143 million. Error rate is 10% or greater, the state share is 15% at approximately $214.4 million. For reference, our error rate in FFY 24 was 9.27.
For SNAP admin, the summary, this program is a 50% state and 50% federal funded. This year, our appropriation reduction was $326,979. So that would impact the federal by the same amount, $326,979. So the total reduction this year for the program was $653,958. The actual expenses for the quarter were $1.8 million. For ID bills, we had $359,000 overspend, but that was just due to, historically, we didn't account for cost allocation for swipe cap, but this year we accounted for that. We're showing that in the fiscals, but we didn't account for that in the budget in the very beginning, but we do have the funds to cover that. Here's a SNAP impact. This is also a 50% state funded and then 50% federal funded, and then also some funds that are 100%. We did have an appropriation reduction of 150,808, so that would impact the federal part by the same amount, and then the total reduction would be $301,616. The actual expenses for the quarter were $809,470. Some of the vendors were just running behind on payments year to date. We don't anticipate anything huge by the year end. And then the small amount of the 770 is just the same issue that we had with the SWI cap hitting that usually we didn't account for in the program, but this year we did. And here's a summary of EBT. This is also a cost allocated fund, so the funding is state and federal. We did have a appropriation reduction in this program of $6,115. The federal impact is $6,264. So the total reduction would be $12,379. The year-to-date expenses for the quarter were $87,651, and we are forecasting to be overspend right now of $148,728, and that's due to data warehouse, M&O. This program has been underfunded related to the M&O.
Temporary assistance for needy families provides cash assistance and supportive services to assist families with children under age 18 and pregnant women. The goal of the TANF program is to help individuals achieve or return to economic self-sufficiency. As a condition of eligibility for TANF, adult applicants are required to attend applicant job search orientation and complete applicant job search activities. Failure to complete the applicant job search program without good cause will result in a denial of the application for cash assistance. The applicant job search started in November of 2011.
Here's just an overview of our TANF funding allocation that goes out to the different agencies and where the funding is going to.
Here are our TANF program metrics. You can see for September of 2025, we received 6,085 applications. We did 507 redeterminations. We issued $2.1 million, and the total recipients receiving TANF were 12,327, with the majority of them being children at 9,718.
For TANF admin, this is 100% federal. The actual expenses for the quarter is $11.9 million. And the underspend of year-to-date is due to mainly the working families. We anticipate that to ramp up, so no major concerns here.
The Indiana Manpower Replacement Comprehensive Training Program, which we refer to as IMPACT, aims to help participants achieve economic self-sufficiency through a combination of education, training, and employment supportive services. Services available include job skills training, assistance with resume writing, interview preparation, access to local job fairs, and employment opportunities. The IMPACT program is available to SNAP and TANF recipients. For quarter one of SFY 26, you can see the total number of IMPACT participants that we had for September was 725. These are our Medicaid program metrics, and you can see a breakdown by enrollment type as far as Hoosier Health-wise, Hoosier Care Connect, HIP, pathways for aging, pathways to aging, and then individuals who are in a fee-for-service category. In September, we had 1.7 individuals on Medicaid, and then we did approximately 116,000 redeterminations and got 68,000 applications. Indiana's Refugee Services provides assistance and services to refugees, asylees, certain Amer-Asian, Afghan and Ukrainian immigrants, Cuban and Haitian entrants, and victims of human trafficking. Indiana Refugee Services monitors program planning, provisions of services, and provides technical assistance to ensure compliance with federal and state regulations regarding the delivery of refugee assistance and services, including cash and medical assistance. All individuals served by Indiana Refugee Services have legally entered the United States through the applicable federal program. This is a wrap-up of the federal fiscal year, and you can see January of 25 was the last month that we received refugees into Indiana through this program. The program is currently on hold at the federal level.
The refugee summary, the funds come from 2 grants, our supportive services, which those are all contracted out in point 3, and then cash and medical, which is funds of the RCA and the RMA. The actual expenses is $3.4 million. We're showing an underspend of $1 million, and that's just due to the federal changes and the hold on the program.
The Burial Assistance Program was established by the state of Indiana to help with burial costs for those who are eligible in specific categories of Medicaid. Burial assistance eligible categories are Medicaid for the aged, Medicaid for the disabled, Medicaid for the disabled working, Medicaid for the blind, Medicaid for individuals receiving SSI, and then Medicaid for individuals who are in room and board nursing home. Maximum benefit amounts for a funeral, $1,200, $800 for a cemetery. These rates were last updated in 2013. In September, we had 429 total burial claims that we processed.
For our burial program, the year-to-date expenses was $1.6 million. And then we are forecasting to be overspend in this program for $2 million, and that's just been historically for the program. The program has been underfunded, so we'll have to find some, use some carry forward funds to cover the difference in that. Our county admin is a cost allocated fund. So this has state and federal appropriation in it. The appropriation reduction for this year was $5.7 million. The federal impact of that would be $8.9 million. So the total reduction for the program was $14.6 million. The expenses year to date were $83.3 million, and then we are projecting $38.2 million as of right now to be overspent in the program. DFR admin, this is also a cost allocated program. So the appropriation reduction here was $105,120. Then the federal impact of that was $149,531. So the total reduction of the year was $254,651. The actual expenses for the quarter was $1.2 million. The ID bills was running over, and that was just due to HR application fee services was higher than we expected. And then we're working with IoT right now because they said that there might be an actual allocation problem. So they're looking into that to see if the expenses are accurate or not. So as of right now, no major concerns in the program. Our IEDSS is also a cost allocated program. The appropriation reduction was $557,486. So the federal impact would be $998,196. The total reduction would be $1.5 million. Year to date, we're showing expenses of $10 million. And then the underspend in point 3 of that 3.3, that was just because of Deloitte is running behind on claim submissions. And then the ID bills we're projecting that some of the ID bills that were coming in were higher than anticipated, so we are projecting that there will be an overspend in our ID bills at the end of the year as of right now. And here's just an overview of some of the major contracts that DFR provides.
And for reference, just to cover, the Knowledge Services GuideSoft Maximus RCC contracts, those are staffing contracts that support DFR operations with contract staff. Mosher and Deloitte support our IT, our public-facing benefits portal, and the internal system that we use to determine SNAP, TANF, and Medicaid benefits. EQUIS is our employment and training vendor that supports the impact program. Phoenix is the document processing. We receive approximately about 1 million pages of documents a month at DFR, and Phoenix processes those, scans them all, makes sure that we get them to the right electronic case file. Conduent EBT handles all of our SNAP and TANF issuance. Conduent Learning and Development is our training vendor. First Data provides some operational support for DFR, and then TOX is an income verification service that we use in DFR operations for SNAP, TANF, and Medicaid.
If you have a question, if you hold up your hand, I can give you a note card so you can write it down. All right. If not, thank you. Oh, sorry, didn't see it. Could you hold up your hand again?
If Congress approves a bill, how quickly will SNAP be turned back on? Do you not know that?
We will have to wait for word from FNS, so I can't really answer that. Since it is that we won't have the text of the bill until it's published and FNS would have it, we would have to wait for direction from FNS as to what our instructions are.
Okay, all right. Do we have another question? Okay, thank you very much. We will have a 15-minute break. And then at 10 o'clock, we will have the Office of Early Childhood and Out-of-School Learning. And Social Services Administration's quarterly financial review. Next up is the Office of Early Childhood and Out-of-School Learning. If you have a question, you can submit that question either by emailing the askthesecretary@fssa.in.gov email address, or if you're in the room and raise your hand, I will give you a note card in which you can write your question down, and questions will be answered at the end of OECOSL's presentation. Thank you.
Good morning, and thanks for everyone for coming to the state fiscal year Q1 quarterly financial review for the Office of Early Childhood and Out-of-School Learning. I am Adam Allison, the director of the office, and we will begin now. The past year has been one of the most consequential in the history of Indiana's Office of Early Childhood and Out-of-School Learning. At the heart of the story was a looming child care cliff that threatened to push thousands of Hoosier children off the Child Care and Development Fund, or CCDF, voucher program. In late 2024, state leaders confronted the reality that $1.27 billion of temporary federal COVID-19 relief dollars used to expand eligibility and boost provider reimbursement rates beginning in 2020 were running out. Without intervention, the almost then 70,000 children and families who relied on CCDF vouchers for safe, affordable care risked losing access altogether. Families faced losing care, child care businesses faced mass disenrollment, and employers braced for workforce instability. OECOSL faced three problems at the beginning of 2025. First, the state of Indiana over-enrolled families on CCDF vouchers in 2023 and 2024. Second, the office in 2023 had instituted artificially inflated CCDF reimbursement rates, also known as transition rates, that did not reflect the true cost of providing child care, and with little to no communication with child care businesses on a wind-down plan. Third, and most importantly, there was no fiscal sustainability plan that existed for the over-enrolled CCDF vouchers or the transition rate scheme after the $1.27 billion in federal COVID funding money ran out in late 2024. Recognizing the stakes, the Indiana General Assembly took historic action in the 2025 session. Lawmakers appropriated $147 million in new state funding to stabilize the child care system in Indiana and protect families already enrolled. This investment is the largest state commitment to child care in Indiana's history, and a clear signal that legislators understood the economic and social imperative of keeping children in care. But the rescue came with hard choices. To stretch limited dollars across tens of thousands of families, the office announced in September 2025 that it would reduce provider reimbursement rates, cuts on average from 10% for infants and toddlers to as much as 35% on average for school-aged children. These rates were not arbitrary. For the first time, they were grounded exclusively in a comprehensive survey of childcare businesses that collected detailed cost data, replacing the outdated market rate approach and unwinding the artificially inflated transition rates implemented in 2023. This shift ensured that reimbursement levels reflected the actual costs of care. Equally important, the office has committed to transparency. This year, the office published its methodology for CCDF reimbursement rates and explained the trade-offs between rate reductions and voucher disenrollment openly. Ultimately, the decision to reduce reimbursement rates rather than end vouchers was rooted in a clear principle. We chose to fulfill the promise the state of Indiana made to the now 53,000 children and families that depend on CCDF vouchers. By lowering reimbursement rates, the state avoided forced mass disenrollment and kept current vouchers intact, ensuring continuity of care for tens of thousands of children and preserving the ability for their parents to continue to work and to better their families' lives. Before I took this position, I was president of a nonprofit in Jasper County that funded childcare. I remember sitting on the OECOSL webinar in 2023 that announced the transition rates and thinking, how is Indiana going to fund this long term? It is simply not sustainable. And also, surely someone is watching the money. Well, it turns out I was right about one of them. I was right about it being unsustainable. I was wrong about someone watching the money. So here we are. The office has done its part as well to maximize existing funding towards CCDF vouchers as well. Governor Braun desires state government to be more entrepreneurial, and we have followed the governor's lead. The office has amended, terminated, or not renewed $30 million in contracts for state fiscal year 2026, and we project a total savings of $75 million over the biennium. These savings have been reallocated to fund CCDF vouchers. By doing so, we increase the percentage of the office's funding that goes directly to voucher payments from 81% to 88%, and reduced the percentage of funding going to contracts and grants from 17% to 10%. And we also reduced the amount of contractor staffing funded by the office by 2/3, and total staffing by 50%. We have done this all over the last 6 months. I'm particularly excited about our new provider help desk that we launched in September. Through leveraging existing state call center expertise by partnering with Indiana 211, the office has streamlined the communication channels with childcare businesses so they can talk to, ask questions of, and receive answers directly from OECOSL, not a third-party vendor. We received over 1,800 calls in September. This project alone will save the state of Indiana $45 million combined over the next 2 state fiscal years, while improving OECOSL's customer service. These savings will go to directly fund CCDF vouchers. Christy Burkhardt and her team have done an exemplary job in getting the provider help desk off the ground. This is how we got here, and this is where we are. Next, I will talk about the future. 3 tenets will guide OECOSL going forward. First and foremost is fiscal responsibility. I and we have a responsibility to Hoosier families, Hoosier childcare businesses, and Hoosier taxpayers to make policy decisions based on the simple constraint of funding. We have, and will continue to have, a laser focus on our costs in order to maximize available funding to CCDF vouchers. Second is transparency. OECOSL will be clear in our financial reporting, our policies, and our goals. Third is entrepreneurial governance. We can reduce costs to childcare businesses through regulatory reform. We can improve our customer service to both childcare businesses and families, and we can be creative in leveraging existing governmental expertise from other areas and bring it to the childcare space. CCDF voucher funding is a long-term problem for OECOSL. It was in 2024, it is in 2025, and it will continue to be so in 2026. OECOSL currently projects no new CCDF voucher enrollments through the end of calendar year 2026. This assumes flat year-over-year federal CCDF appropriation and is subject to change at any time. OECOSL simply does not have the funding available to prudently begin enrollment before that date. Regarding the On My Way Pre-K program, we announced earlier this year a reimbursement rate at the statutory maximum of $6,800 per voucher and capped the enrollment at 2,500 vouchers. In past years, federal funds were braided with state appropriated funds to increase the On My Way voucher reimbursement rate. The federal funds of prior years are gone. Also in past years, CCDF vouchers were flipped to On My Way vouchers solely to juice year-over-year enrollment growth in the On My Way program. I wish I was making this up. I am not. Currently, 2,124 children are enrolled in the On My Way program, and we do not expect to reach the 2,500 enrollment level. In my opinion, the combination of braided funding and flipping vouchers to artificially increase On My Way voucher enrollment has done a disservice to all parties involved. Prior years' actions of this office have allowed a well-intentioned policy program to become operationally ineffective. This year's events underscored the fragility of Indiana's child care system, how quickly temporary funding can create unsustainable expectations, and how difficult it is to balance the need of families with the financial realities of childcare businesses. Still, the General Assembly's investment, the shift to cost-based rates, and OECOSL's new transparency prevented a devastating cliff and set a precedent for more accountable policymaking. As Indiana looks ahead, the story of 2024 and 2025 will hopefully be remembered as a turning point. A year when policymakers chose to prioritize children and families, even at the cost of short-term strain on childcare businesses. And when the state made clear that childcare is not just a social service, but a cornerstone of Indiana's economic future. I will now turn the presentation over to Sue McKinney, OECOSL's Deputy Director, to present data on vouchers and child care supply, followed by Tammy Kiefer, OECOSL's Controller, to present OECOSL's financial data for Q1 state fiscal year 2026.
The Office of Early Childhood and Out-of-School Learning has two primary responsibilities: to regulate and license child care centers, ministries, and homes, and to administer the CCDF and On My Way pre-K programs. CCDF is a voucher program
I'll do this.
Thanks. To help families pay for childcare so they can go to work, school, or attend training. It also improves the availability and affordability of childcare. There are three buckets used to fund vouchers. First, the subsidy reimbursement rate reflects the provider cost to meet health and safety standards and is paid directly to providers. Second, the copay is the family's share of the voucher payment and only applies if a family's income exceeds 100% of FPL. The amount is based on income and years on program, and if applicable, reduces the provider reimbursement. Third, the overage payment is the difference between the provider rate and the subsidy reimbursement rate. Any overage is collected by the provider. Here are the latest voucher statistics. CCDF and On My Way vouchers are 55,000. The wait list is near 31,000. And in most cases, our families are using vouchers to go to work, and families are headed by a single parent with income less than 127% of FPL. In September of 2025, voucher totals are down from their peak of 69,000 in December of 2024. This year's On My Way enrollment is down and will not reach the 2,500 enrollment cap set in the spring, and our reauthorization rate remains steady at 75%. Due to re-implementing the waitlist, the number of infant vouchers are down 95%. We expect to see enrollment continue to shift to older age groups. As the charts show, regulated childcare capacity increased as voucher enrollment increased. Today, regulated childcare capacity continues to hover around 180,000, while voucher enrollment continues to decline. We will start including regulated childcare supply statistics to give a transparent picture of the overall childcare supply in Indiana. To date, total regulated childcare supply and the number of locations remains fairly consistent since last quarter and is up from December when waitlists were reinstated. And then lastly, over the past year, capacity in childcare centers is up over 8%. Capacity in homes is down 3%, and there is little change in registered ministries.
I'd like to begin by discussing the sources of our OECOSL funding for subsidies that are available for use. We'll talk a little bit about the Child Care and Development Fund. The Child Care and Development Fund actually consists each federal year of 3 separate grants, a mandatory, a matching, and a discretionary, that are bundled together and are available funds for us to use for a period of 3 years. So in any given state fiscal year, we have multiple federal years of grants available to use for our subsidies. And it's important to note that simply because of the rules around the grants that require for us to fix the entire minimum of 53-week subsidy with the grant year in which it was originally started. In addition to our CCDF funds, we have available funds from TANF. Indiana is allowed to divert a portion of their TANF funds over to use for childcare. We also have state funds, our Early Childhood Learning Fund, which is appropriated of $39.4 million, which satisfies our state matching federal requirements and our federally required state maintenance of effort, which means the amount of state money we have to spend in order to receive the federal funds. We also have our pre-K education fund, which funds On My Way program and also has a portion that was appropriated to also fund the match for CCDF. And one-time state funding during this year in 2026 is the $147 million that Adam discussed earlier. All of those things combined to support our CCDF subsidy vouchers and our On My Way pre-K vouchers. Our overall financial outlook as of September, we have, as you can see in the bottom line there, a slight variance. Our budget numbers are budgeted based on the funding that is available, and our forecast numbers are based on our outlook and what we believe we have obligated to pay. You can see we still are in a bit of a deficit in 26 where we don't have quite enough funding at this point to cover all of our expenses under CCDF, and it's mainly due to not wanting to release families and continue to cover them. We have improved greatly since July, from about 100 million down to the 30 million you see today with all of the efforts that have been made, and we expect we will continue to improve throughout the year. So hopefully as we go on in the future quarters, you will see that deficit decrease. As the whole office in OECOSL, I just would like to point out that the majority of our expenses, as Adam pointed out earlier, are entirely used in our social services payments, and you can see that that's where the shortfall is coming. To talk specifically about CCDF vouchers, I want to look at the social service payments. And as I said before, the grant year that the funding is attached to is based on when that first minimum of 53 weeks was obligated, which is why we have split out 24, 25, and 26 grant years. As you can see, our problem falls into those that are in 25. They were obligated in 25. We were able to cover the over obligations in 24, but as we've reauthorized in 25, we have our shortfall there. So that's where we're looking to improve as we go on. Flipping over to the On My Way pre-K fund. At the time we budgeted, as he said, we budgeted 17 million, which represented in subsidy, which represented the 2,500 children. We are under enrolled to that 2,500, so we have a little bit of a positive variance in pre-K. The remaining slides are about funds that we cover that are not related. These cannot be used for subsidy, but they are other programs that we do in the office. Our preschool development grant we received, we are a little bit overspent during the year, but that is because we received additional funding that wasn't planned for from Department of Education. School-age child care fund is right on track. We think we'll come in right on track as to where we had planned. Our Head Start fund, I also believe we should come in track in total as to where we had budgeted, and that matches our grant funds. The Social Services Block Grant Fund is in conjunction with Head Start. It's funding provided to us by DCS, and it's used entirely for teach scholarships for providers to get education. Child Care Licensing Fund is used for childcare licensing standards and training for childcare workers.
So that is our presentation for the Q1 State Fiscal Year 2026 Quarterly Financial Review. I believe, Marcus, I will hand it over to you for questions.
Again, if you have a question, you can email the Ask the Secretary at fssa.in.gov email address, or if you raise your hand, someone will get you a note card so that you can write your question down. If your question isn't read here today, it was either a long, multifaceted question, in which case we will respond to all of those questions in writing, or I mean, it was a statement disguised as a question, in which case we're not going to be answering those. So the first question we received is from Holly Maxwell, the owner of Little Angels. When will the CCDF waitlist be lifted?
So thanks for that. And answered it in the presentation, but we'll say it again. We project not to enroll any new CCDF vouchers until the end of calendar year 2026.
And what funding levels need to be reached to open up the waitlist?
So we need to be at a point as an office that we feel comfortable and that, let me take a step back. What's happened here in the last year with OECOSL can never happen again. We cannot be so far off from what we enroll versus what our funding is. It just cannot happen again, right? Many business models in the childcare space depend on the sensitivity of the availability of vouchers. We are going to be extremely prudent and make sure that every voucher that we as an office enroll in the future that we can fund for as long as that family needs that voucher.
And we have a question about the cost survey. Can you talk about like what numbers were used to come up with the average costs?
Yeah, so we had, from that survey, we had over 1,000 childcare providers submit responses for it, which is around a quarter of all childcare businesses and license in Indiana. We used that data, we looked at by type, so center, ministries and homes, and we also looked at it by geography as well, whether it's urban, rural, or that suburban or mixed area. Through doing that, going through that process, we came up with specific reimbursement rates that we believed more accurately reimbursed for the true cost of providing childcare in the state of Indiana. It's a process that I'm very comfortable with of how we did it, and we are also going to be looking to start this back up next year as well for the next round of reimbursement rate surveys.
Yeah, the next question I had actually was to what you just said in the end. Could you talk a little bit about like the process moving forward and how often rates will be reassessed?
Yeah, so we'll start the process next year. Like I said, we will communicate as best as we can over a long period of time to make sure that as many providers as possible in childcare businesses can provide their cost survey data. The more providers and the more businesses that we have respond to this means that we have more accurate numbers. And that's something that we want. We want accurate numbers. We want to be able to say these reimbursement rates are what the true cost of care is for childcare in Indiana.
What percentage of childcare providers were included in the last cost survey?
25%.
And can you talk a little bit about OECOSL's long-term vision for CCDF vouchers?
So our vision for them is first and foremost, our policy is we will continue to uphold the promise that the state of Indiana has made to existing families that currently hold CCDF vouchers. That's where we are today. When we get to a point where we can start enrolling kids in the future, we will. And it is off in the future, right? It is, we project currently it's this end of next year. That's what it is.
Okay, thank you, Director Olson. If anyone has any further questions, you can still submit them to the email address or fill out a note card, and we leave your contact information and we will respond to you with answers. Thank you. Good morning, and thank you for joining us for the Indiana Family and Social Services Administration's quarterly financial review. Next up, we have the Division of Mental Health and Addiction. If you have questions, you can email the Ask the Secretary at fssa.in.gov email address, or if you're in the room and raise your hand, we will get you a note card so you can write down your question. Questions will be answered at the end of the presentation. Thank you.
We barely fit. Good morning. I am Sarah Saylors, Director for Division of Mental Health and Addiction. I will have the team introduce themselves as they begin the presentations. Our plan for today, we're going to talk a little bit about high-level overall statistics, but then we'll dig into each of the 11 program areas, and you'll hear more on data and then the financials for each of those areas. We will do some high-level DMHA-wide data and financials, and then we'll wrap it up with our hospital information. So with that, as you know, our DMHA funds mental health treatment for both SMI, which is seriously mentally ill individuals, and SED, so seriously emotionally disturbed individuals. Those are patients who are either over 18 for SMI and under 18 for SED. Those patients also are at or below 200% of the poverty level. And a year to date, so far in state fiscal year 26, we've served just over 91,000 individuals in those programs.
Regarding CCBHCs are the comprehensive range of addiction and mental health services for anyone seeking services regardless of their diagnosis, insurance, or place of residence. It is the new program that we are working on to try out a new model of care for community providers for mental health and addiction services. We still have the 8 pilots that we are working with that we had presented on last quarter as well. They provide the 9 site-specific services. They report on 21 required quality metrics and goals, and they have the 10 and 13 required and recommended, respectfully, evidence-based practices. In terms of CCBHCs, one of the quality metrics that we have are increasing screening for social determinants of health to inform decision-making. The social drivers of health are critical factors like stable housing, reliable transportation, adequate food that can influence clients' health outcomes. The purpose of these screenings is to see how clients are doing, what their real problems are that may be affecting their ability to care for themselves, that may be causing real impact to their ability and barriers. And what we've seen is that the CCBHC currently are at 77%, so they're approaching that 80% goal that we set for themselves in order to have the screenings. And 46% of the clients that have been screened have at least one SDOH issue. The highest SDOH issue that we've seen is transportation, and that's really impacted in the rural communities. Currently, in the last 2 quarters of the CCBHC program, a total of 44,290 unique individuals were served in SFY 25 Q3 and SFY 25 Q4. The unique individuals served in each quarter respectively are 35,620 individuals in quarter 3 and 36,396 individuals in quarter 4, and those are both unique individuals served. Now we're going to look at a story which looks at one individual, David, and his journey through crisis under the 988, 911, and 988 systems. David is a lifelong Hoosier. He's 23 years old, born and raised in Indiana, and loves to show it off with the flag in the background. He had an ordinary childhood, a standard upbringing, and he's a high school graduate. But along the way, David has experienced some new mental health challenges, stress causing mental health issues, and has started to experience some private episodes of psychosis. Due to limited support and resources, those private episodes have caused him to withdraw from his family more and more, and he has never seen a counselor or a therapist. As a result of this, he recently lost his job, he can't afford to meet his basic needs, and he's on the verge of homelessness. So, under the 911 system, he starts to visit his family, he becomes extremely upset, and one day he gets really agitated and upset, and his family is unable to calm him, and they believe he needs professional help immediately. His family immediately calls 911, and they dispatch EMS and law enforcement to the scene. EMS and police arrive, but due to his agitation with his previous past experiences, they're unable to de-escalate the situation. EMS takes him to the ER. He doesn't immediately get access to mental health care, and he's admitted into the hospital. He's discharged without a safety plan, and he doesn't have connection to mental health resources. He doesn't really have the capacity in this episode of psychosis to look for continued treatment and care. He experiences another behavioral health crisis in the next few weeks, and again, possibly ends up with another 911 call and EMS visit. Now, under the new crisis continuum, the vision is that instead of years, it's months to go through the treatment in the community. And specifically, mental health and behavioral health care are nonlinear, and the hope is to streamline the system to make it easier for all individuals to navigate, especially those who are in crisis. Again, David has the same situations as for his background, but this time, instead of calling 911, David's family calls 988. The trained crisis specialist provides initial support to help David's family support him. They're able to calm him down a little bit, but he's still very, very upset and agitated. The crisis specialist suggests someone to respond to his location, specifically a mobile crisis team, and asks for consent to send that mobile crisis team out. David and his family consent to the mobile crisis team being sent out. The 988 contact center supervisor dispatches the mobile crisis team. The crisis specialist remains on the phone until the mobile crisis team arrives and confirms contact with David. The mobile crisis team then arrives. They de-escalate the situation and provide support to David and his family. David is able to connect with the certified peer who understands what David is going through. David is feeling much better, but the mobile crisis team suggests that he comes to a safe place for help, a crisis receiving and stabilization service center for further assistance, stabilization, and connection to resources for continued assistance. David consents and his family consents, and the mobile crisis team transports David to the CRSS site. That's a crisis stabilization center for up to 23 hours of stabilization, care, and referrals. He connects with his certified peer who understands the situation and helps him feel comfortable, helps him de-escalate, and shows him that recovery is possible. The CRSS site follows up with David to ensure his safety. They check in on his connection with resources and determine if any other referrals are needed. David's connected to effective behavioral health services in his area, which help prevent future crisis and act as a trusted resource if a crisis does arise. So what changed for David in these two scenarios? After the crisis diversion, David will receive crisis care across a continuum by contacting 988 for someone to contact, someone to respond, and a safe place to help. David will have a personalized safety plan to follow in the event that he experiences another crisis. David's healthcare providers will be within the same network, allowing them to easily communicate with each other. And David's care coordinator will keep track of him throughout his treatment. Now, the average cost for a single crisis diversion under an EMT dispatch that leads to a one-day ER stay are $955, while the average cost for a single individual to have a mobile crisis team respond is $490. So for taxpayers, that means an estimated cost savings for the EMT dispatch that leads to a one-day ER stay over the mobile crisis team to be $465.
Okay, I think that the bowel chart that you, I think that's a really effective story that you've told there, and the way we would like it to be. And can you flip back one more slide?
Of course.
Okay, so the numbers you have here, Paula and I and you guys have been working on, we're not exactly, I'm not exactly sure that these numbers are completely correct yet, but we'll continue to refine them, and I'd be appreciative of other people who are involved in this, helping us understand the cost structure here in terms of what's a marginal cost and what's a variable cost, and what are fixed costs, et cetera. So understanding this so we can make an argument both to the federal government and to the legislature about the continuation of this program, I think is an important thing to be able to do, but we need to have confidence in our cost numbers. And Sarah and I talked about this a couple times. I'm not completely there yet, but you guys have made a really good start of working through these cost numbers. Thank you.
Thank you, Secretary Rowe. Just a couple clicks and we'll get right back to it. Now, in terms of 988 data, for July and August in state fiscal year 25 and state fiscal year 26, in terms of those three pillars, someone to call, someone to respond, and a safe place to go, the differences that we've seen are an increase. So in state fiscal year 25 in quarter one, in July and August, approximately 7,500 were seen in terms of 988 calls, while in state fiscal year 26 quarter one, we saw 10,600 in July and approximately 11,500 in August. So quite an uptick there. In terms of mobile crisis responses, we saw an increase as well, which is to be expected with an increase in calls. Here we saw in quarter one of 25, 775 in July and 836 in August. And in quarter one of 26, we saw 1,003 individuals in July and 1,068 in August. Then in crisis receiving and stabilization centers, we saw a major uptick, which is to be expected with that increase. But what we saw is in July, 606 individuals being served in quarter one of 25, and in August, 566 individuals. And again, we did see that trend go down from July to August, but the numbers were much larger in state fiscal year 26, with 1,766 individuals in July and 1,675 individuals in August.
Good morning, I'm Kelly Welker. I'm the Director of Addiction and Prevention Services here at DMHA, and just want to kind of highlight some of our funding that we have. So starting off with our state opioid response grant, which is a federal discretionary grant, and this is for persons with opioid use disorder or stimulant use disorder. So a couple of the initiatives, we fund recovery resident stays for people who have either OUD or stimulant use disorder that don't have access to a third-party payer. We also partner with Overdose Lifeline to purchase and distribute naloxone to our local health departments, our community partners, as well as laypersons. Some of our state treatment funds we use to support our regional recovery hubs, which allows the opportunity for Hoosiers to connect with a certified peer support professional to get access to treatment and recovery supports, as well as we partner with Indiana 211 to provide lift rides to those who need access to treatment services. And then lastly, with our substance use prevention, treatment, and recovery supports block grant, we use that to support people in residential ASAM 3.1 or 3.5 level of care that don't have access to a third-party payer, are below the 200% poverty level, as well as our priority populations, and that would be pregnant women or persons who inject drugs. And highlighting just some of our metrics with that, for the first quarter in state fiscal year 26, we provided 775 lift rides just through our 211 platform. 221 people were served through our DMHA electronic billing system to have their recovery residents room and board paid. Number of unduplicated participants that received substance use treatment is 869 in the first quarter of state fiscal year 26, and almost 91,000 doses of naloxone were distributed during that first quarter. And I did want to highlight, we do have a quote you can see at the side of, "These funds gave me an opportunity to battle my addiction head on. Had it not been for DMHA funding, I wouldn't have had the opportunity to work for Goodwill and be promoted to manager of donations."
Before we get, are you, I thought Becky was getting ready to speak, but maybe I'm wrong. So that's fine.
The other blonde, one of the three blondes on stage.
I'm just going to leave it there. Not going to touch that one. Would you mind flipping back to the last slide? Okay, so at the next time we do a QFR, let's put the Medicaid piece into this as well, right? And start looking at the Medicaid piece and this in total. So we have a broader view of the state's engagement in addiction services. So we think that we spent about $700 million within Medicaid on addiction treatment. How much of that is direct services, or how much of that is stuff like Suboxone? I don't know that we completely understand yet to tease out, but I think it's important when we talk about the size of the state opioid and addiction problem in the state of Indiana that we look holistically, because this is just the tip of the iceberg here, right? Most of that spend exists in Medicaid, and in OMPP we tend not to focus on that. So I want to bring that into this conversation.
Hello, my name is Rebecca Chahan, and I am the controller here at DMHA. First, we're going to talk through the substance abuse treatment financial summaries. The primary supporter of this program are the State Opioid Response, the SOAR grant, as well as the SUPTR's Substance Use Prevention, Treatment, and Recovery grant that Kelly has mentioned. That makes up the majority of the federal funding that is here. We do spend that on primarily contracts and direct services. Now that we're using the DEB system to provide payment for direct services, this is something that we're monitoring very closely because those are not encumbered on a purchase order the way that our traditional contracts would be. We do also support the staff of Kelly's team and have some smaller grants as well. We also use some dedicated fund in our prevention fund and also our gambler's assistance.
And moving on to our problem gambling. So this funding is used to support providers who provide gambling education and treatment, as well as the gambling hotline. And some of our program metrics for the first quarter of state fiscal year 26, 327 unique individuals were served by problem gambling providers. We had 154 new intakes. 146 new people voluntarily signed themselves up for the voluntary exclusion program. We had 44 new participants sign up for the internet self-restriction, as well as 193 calls to our problem gambling specific hotline.
From the financial side, this is supported entirely by the dedicated fund for gamblers assistance. We do support some staff in this as well as contracts. The primary cost, though, is our direct social services payments that are processed through our WITS system.
And moving on to substance use prevention, as part of our substance use prevention, treatment, and recovery supports block grant, 20% has to go towards primary prevention, and so that's what this funding is going towards. And that is used to provide evidence-based programs for adults, youth, after-school programs, as well as substance-free events. And then the map highlights where those initiatives are currently held throughout the state.
Expenses here primarily supported by the SUPTR's federal grant with some light dedicated funds as well. Primary costs are through our contracts. We're encumbered right now at $10 million for the year.
And moving on to our opioid settlement funds, this slide kind of highlights the breakdown of Indiana's expected to receive over $980 million over the next 18 years. The Attorney General's website houses all of our settlements that we receive, and then kind of a breakdown of the split between the states and the local units of government.
This program is supported entirely by two dedicated funds, one reverting and one non-reverting. Primarily, we've had contracts in the past. However, we are moving to the DEB system beginning this year for direct services payments.
And moving on to our opioid treatment programs, also known as methadone clinics, we currently have 26 throughout the state. These are highly regulated between SAMHSA, DEA, Division of Mental Health and Addiction, as well as the Indiana Board of Pharmacy, and they must be accredited by a national body. And then here's just a map of where all of our OTPs are throughout the state. And some of our program metrics for the first quarter of state fiscal year 26, we had 11,610 people served in the first quarter, just over 1,300 admissions, and just over 1,300 discharges.
We do have a dedicated fund specifically for methadone clinics. However, as this program continues to grow, we rely on our non-reverting opioid settlement fund to cover anything that the methadone dedicated fund does not. We are primarily here in contracts for our spend.
Good morning. I am Becky Buhner. I'm the Deputy Director, Chief of Staff at the Division of Mental Health and Addiction. So Recovery Works, this is a program that is known in the appropriation as the Mental Health and Addiction Forensic Treatment Fund. And this past session, it was allocated $12.5 million. And the intent of this fund is to allow for individuals that are coming either out of an incarcerated state or prior to going in, if they don't have access to a funding stream to support treatment, they can use Recovery Works funds to get access to treatment that is similar to the services offered through Medicaid, as well as there's recovery residences, which is not funded by any other source outside of some grants that we have, and then Recovery Works. And some other faith-based and recovery community organization programs. So looking at the metrics for Recovery Works, the total spend, as you can see for state fiscal year 25, this is just the funding that went towards direct service payments. So again, that is access to individual therapy, group therapy, peer support services, or recovery residences. For state fiscal year 25, we were just over $6 million. And so far this year, we are just over $1 million. The total number of newly enrolled participants is just over 1,200 for this quarter. And as you look down under the number of referrals through the public advocates in community reentry, the PACE access site, that number is a little bit different. We do have the opportunity for individuals to self-refer. And so once those referrals are received, then they get enrolled into the program. And so some of those enrolled in this first quarter might have submitted a referral during the last state fiscal year. And then
Becky, can I ask a question?
of course you can.
This is one of maybe 3 programs the agency runs, all called PACE, which do significantly different things.
Well, so technically, this is an organization, an entity that exists in Marion County. And so it is an agency that we contract with. So we have no say over the naming of this agency. And they've been around for a very long time. I don't have the number memorized, but they've been around for a very long time. So unfortunately, we can't rename them. I don't think they would appreciate that. So Unite Indy is a contract that we have that allows for transportation to employment. And so what this agency does is they lease vans from Enterprise or from a rental dealership, and then they connect with employers. And so individuals drive the vans, go around, pick folks up, door-to-door transportation to work, and then back home. And we've seen a lot of success with this program with individuals who they have previous incarceration, they have felonies. And so these employers then are noticing when transportation is provided, folks, their retention rate and their success at keeping their employees, and their employees then being able to establish themselves through getting their own vehicles and such moving forward. It's been very, very successful.
We do have a state general fund that supports the Recovery Works program. It was reduced pretty significantly by 50% in this last appropriation, so we are learning to live within our means. This is primarily spent in contracts and our direct service payments. Moving on to the mental health funds recovery. This is an area where we recover some of our Medicaid funds. We do have some direct costs here with our contracts. This is also highly involved with what you'll see in a later slide with our Intercare grant, which is our contract, which is our largest contract. Intercare processes about $93 million a year in Medicaid recovery funds. But this is just the administrative portion.
So at DMHA, we have a quality assurance, quality improvement team, and this team is fully funded through the federal block grants as well as some of the DMHA admin. This team is responsible for certifying all providers that come through DMHA. Mental health providers are not certified by us, but all addiction providers as well as the community mental health centers. And then there's also some designations that we are now doing around the certified community behavioral health clinics, ASAM, which is the American Society of Addiction Medicine. And so some of those programs our team has already talked about. So they do the designations for those as well. This team also reviews the complaints and the calls that come into the consumer service line. So you can see there we had 179 provider complaints through that consumer service line, and then also 560 reported critical incidents. And so we have a very small but mighty team, and that team does review and investigate all of the complaints and the critical incidents that come in. So through some of our site visits, you can see here the trends that our team has been noticing. A lot of this really goes back to documentation. If I were to give you one word as what is the trend when we see challenges or deficits in our site visits, it's all about the documentation. On this, you will see the scheduled and unscheduled visits. Just want to make a note that the unscheduled visits mostly only occur with the private mental health institutions. Those are required to be unscheduled so that providers are not aware of us coming. We also do some unscheduled visits when there are complaints or critical incidents that we receive that we feel we need to go out and check on. And so this gives you the number of visits that were done by each one of our teams. As you will see here under recovery residences, we have a contract with another entity that investigates and does the complaints for the recovery residences. So that is not an area that DMHA has authority. And then on this, the total corrective action plans, the number of providers that were put on conditional. And I just want to make a note that conditional can mean multiple different areas. So it's possible that we go out and we do a review and that provider is required to be accredited by CARF or JCO, and that site visit by that entity, for which they have no control, has not happened yet. And so we cannot issue a new certification for them without that CARF or JCO accreditation. So at that time, we would put them on a conditional status, meaning there is a condition connected to their certification for DMHA, but it's an administrative and it's at no fault necessarily of that provider. And then there are also instances where we put individuals on conditional, where we go out and we find that there are areas of concern and that there's potential patient risk. And so we will put them on conditional for that as well. Most of the time, incidents where there are challenges or risks or concerns around safety are what lead us to the terminations, which you will see we had 2 terminations of residential providers this past quarter. And I just want to make a note that we do now have on the DMHA website, if you go to the quality assurance, quality improvement site, that page, there is in the middle a link to mental health and addiction providers. And if you click on that, it will take you to a list of all the DMHA certified providers, and it will let you know their status. So if they are put on conditional, that will show up on that list that they are on conditional. If they are not on that list, it means they have since been terminated. And so that is one of the tools we are now using to make sure we're communicating more effectively with you all around the status of our certification of our providers.
Our administrative program utilizes both state funds and both of our block grants to support our costs. This is primarily where we support our staffing, our salaries, and other operating. And that is both state funds and portions of our block grants. Moving on to our major contracts, as I mentioned, the Anticare contract is our largest one. They have a small administrative portion, but primarily act as the fiscal agent for our mental health funds recovery program. We have aggregated all of our CMHCs and CCBHC providers as the second largest group. We do have additional contracts here for you to review as well. For our non-Medicaid summary here, we can look at all of our programs. These were all summarized or detailed in the previous slides. In the grand scheme of things, I think that we're going to end the year in a pretty nice place. And our funding breakdown here, we are primarily state and federal. We do have some light dedicated as we're moving into this new biennium and learning to live within our means and dealing with the closure of some of our former federal contracts or federal grants. We are going through an audit of all of our staffing to make sure that staff are being billed in an appropriate way and that we're utilizing our funds to the best of our ability. And then for our Medicaid summary here as well, I know that these numbers will be reflected in the OMPP report, but these are the ones that directly hit the DMHA program.
Spending inside of HIP on these similar programs, and I want to make sure we're capturing that and articulating it a little bit differently than we are in the silos that we're in.
Well, good morning. Katrina Norris, Executive Director for the Indiana State Psychiatric Hospital Network. As a reminder, the Indiana State Psychiatric Hospital Network is a critical component of the state's continuum of care that includes the 6 state-operated psychiatric hospitals serving both civil and forensic populations. This slide shows some data from the number of patients served in respective state fiscal years, really highlighting the number served across the 6 hospitals, and again, emphasizing the importance of inpatient psychiatric care for high acuity individuals. And given the demand and occupancy of our network, we remain on a significant adult wait list. You can see, so far this state fiscal year, we are at 256, and that would seemingly be low for one quarter in comparison. However, the occupancy is bottlenecking, if you will, our ability at this point. This slide is our occupancy at each location for the first quarter. So you can see most hospitals reported occupancy between 90 and 95%. And this slide represents our length of wait in Q1. Obviously, the length of wait at each location is impacted by bed availability. And sometimes we run into factors there, things like gender, population type, staffing. So those are averages for the first quarter of the state fiscal year. In regards to our adult patient population, as I mentioned, we're on a pretty significant wait list. This is one of the factors as to why. And this shows patients admitted in Q1 of this state fiscal, as well as the patients we are currently serving. So the majority of admissions and current census are in fact forensic patients. And I need to, after yesterday's event, distinguish that forensic is a very inclusive term, but primarily these are incompetent to stand trial orders. So we have a variety of forensic patients, including DOC outdates, not guilty by reason of insanity, but this is primarily the incompetent to stand trial, showing the growing pressure on forensic psychiatric services and the need for expanded capacity and diversion strategies, which we are very diligently approaching. Our staffing in Q1, you can see there's 1,614 in Q1 state FTEs. Our contractors averaged 29.8, showing a slight decline month over month. Staffing, like most of you understand in this space, remains a key operational focus to maintain quality care and meet the rising demands on our system. Our contract summary is here. Total contract value across these vendors is $78.7 million, with $1.8 million spent thus far in the state fiscal year. Our major vendors include Cura Hospitality and Community Health Network is noted there. Those are our food providers at the 6 hospitals. So food services. Cerner is our it's Oracle. Cerner Oracle is our EMR provider, and Syra Health is part of our staffing, our contracted staffing. So it's all the things you need basically to run a hospital: food, medicine, staff, and an electronic medical record. This slide has been showed several times, showing the year-over-year growth of those incompetent to stand trial orders, and noting the 398% increase in the past decade. So the state hospitals continue to struggle to meet this demand, and it has prompted alternative models like our Project Create partners, as well as ongoing partnerships with key stakeholders such as the Office of Behavioral Health within the Indiana Supreme Court to address this issue. This is a projection slide, and it really tells the story of what we have to do to plan ahead to maintain a model of care that we can afford. So as of October 16th, we had received 551 incompetent to stand trial orders. And as a reminder, we have 809 beds total. That includes our youth beds. So you can imagine this projection is quite concerning. And the agency continues to work diligently in our efforts to combat this national crisis. Across the United States, the competency to stand trial crisis has literally become a public health emergency, with thousands of individuals with serious mental illness being held in jails primarily, not because they've been convicted, but because the system can't keep up with the demand for evaluations and restoration services. So in short, the competency crisis is not just a legal issue. It's a humanitarian one, and it calls for urgent coordinated actions across mental health, judicial, and legislative systems to ensure that these individuals receive timely and appropriate care, and that justice is not delayed by these systemic failures. Our alternative partners metrics are here for the first quarter of the state fiscal year. Project Create is a private inpatient model that offers an alternative pathway to competency restoration services for individuals who are low acuity justice involved and have been determined to be incompetent to stand trial being served outside of the state psychiatric hospital network. You can see there that the admissions increased from 6 to 12 in September, and the active patient count rose to 31 by the end of September. And this is the contractual metrics where you can see the contract value as well as the year-to-date expenditures. We currently only have 2 providers because the contracts expired with 2 of our previous partners. So although Vala Vista and Wellstone wrapped up their services, we certainly appreciated that partnership as we worked through this. And combined total contract value on this slide exceeds $50 million, but that was some carryover and extension time. Year-to-date, $1.84 million have been spent. These contracts really expand our capacity to reduce the wait times for competency restoration. Our overarching financial summary here in Q1 does show year-to-date expenditures at $51.9 million versus the $55.5 million that was budgeted. Our largest expenditures being the Neurodiagnostic Institute and Richmond State Hospital. I should note both of which complete the most admission and discharges for the network, so they have a rapid pace of admission and discharge, hence the expense in serving a greater volume of patients. The variance of $3.68 million indicates underspending, largely due to the staffing and operational efficiencies that my team members have executed perfectly at this point. I'm incredibly proud of my team for the efforts they've made. However, noting we are early in the state fiscal year and we must be prepared to continue our efforts to combat the forecasted variances. This is just a slide that shows you the breakdown. Again, probably nothing to anyone in a healthcare space is surprise. Our largest expense is salary and benefits. And year-to-date, $43.6 million in state funds and $8.3 million year-to-date in the mental health funds. So total funding aligns with the expenditures, and although the mental health fund had a variance, a lot of that is due to timing and allocation shifts. Happy to share with you today our network initiatives. There has been a lot of work, again, hence my pride for my team members and the work that they have put forth. We've really focused on staffing and restructuring across our network. This includes significant clinical program revisions, youth admission triaging. The Evansville and Indianapolis team have done impeccable work, collaborative work together to assure that our youth in Indiana receive the right care at the right place with little to no wait time for state hospital beds for youth that need our level of care and our clinical expertise. In addition, the hospital leadership has went above and beyond in the discharge work group, and this work group is done at the local level monthly, and then they report up, and I review all individuals in our hospitals that have been with us a significant amount of time. We assess the individuals that present as unrestorable and try to work collaboratively with our key stakeholders and partners. Many of you I see here today, so thank you for that continued collaboration to try to find solutions to successfully and safely discharged state psychiatric hospital patients into your communities. Again, these initiatives are all targeted to improve our throughput and to reduce the bottlenecks and obviously enhance patient outcomes. Any questions? I may be sorry I asked that. Secretary, please.
First of all, thanks for your work yesterday with the Budget Committee. I thought you did a really nice job of kind of outlining that plan. So can we flip back to the slide that has 8? And I'm going to,
You want the admitted and
no,
serving?
keep going back. There you go. Okay. So let me make sure that I've got these numbers correct, right? So I think you know where I'm going. So in 2026, right, we estimate about 845 competency restoration orders that we will receive.
In 26. And
26,
these are
yeah.
calendar
Right,
year,
right,
not
right.
state
No,
fiscal, sorry.
Okay, that's fine. Right, in that upcoming calendar year. And I believe it's 100, on average, it's 100 days to regain competency. And in some respects, we're not really treating the underlying mental health issue. We're treating them to the point where they can assist in their own trial. Is that correct?
That's correct. There may be medication.
And we're spending, whether it's inside of our system, or inside of the vendors' systems, it's about $1,000 a day. So 845 times 100 times 1,000 is $84 million. And that's $84 million of all state money, right? So the state mental health hospitals have become an adjunct of the criminal justice system, and I don't think that was ever their intent, right? I mean, the bowel slide that you referenced, right, earlier, that when that person has their first psychotic break, sometimes the right answer is to get them care and treatment at a state hospital. I mean, that's why we built the thing out at Community. At least that's why I was trying to get it built last time I was here, right? Was to aggressively treat people for mental health, with a mental health illness, not to get them ready to stand trial. So I think you're doing a great job of more publicly discussing this as you, I believe, properly characterize it, a public health emergency. But it is a relatively speaking slow-moving one, and we have no place to treat seriously mentally ill patients. That's the whole point of having the inpatient networks that we have. So I just wanted to highlight that for others in the room, that the $84 million in pure state money, that's an awful lot of cash for us to be spending and not really even just kind of seeping through the floorboards, right? So that's more of a statement than a question. I apologize, Marcus. I know I'm not supposed to make statements.
It can slide this time. I have 2 questions from Andrew Nielsen. If anyone else has questions, you can email them to the Ask the Secretary at fssa.in.gov email address, or if you hold up your hand, someone will get you a note card so that you can write down your question, and we will make sure to get those questions answered unless, as the Secretary pointed out, you're just making a statement disguised as a question. The first question from Andrew is, what causes 23% of CCBHC clients to not get screened for SDOH?
That's a good question. I think it's a mix of multiple things. I think it's a mix of the fact that it is a new piece of the workflow, as well as changes in EMRs that have to be made, capturing that information through the codes and the work that we have to do with data. And so it does take a little bit of a slow shifting to get everyone moving in that direction, get the data right. And so it takes a little bit of time, but I think with where we're at, we probably will reach 80% our goal by the time that we're at the end of the year.
And the next question is there any consideration to extending CRSS services beyond 23 hours?
It's a good question. There are limitations federally on that. And so that is something that we're,
You want me?
yeah, I want you to take this piece.
We are actually in conversations right now with our current provider network around CRSS. And it is in code for Indiana that is 23 hours, or I'm sorry, less than 24 hours. And so there are some statutory limitations that we have right now. But also, this service is so new for us. And some of the research that is coming in is showing that these sites can be used beyond 24 hours. However, we have not gotten there yet with Indiana. So that is on our list to talk about. We just started, very timely question. We just started those conversations a couple weeks ago and plan to continue them. And hopefully we'll, through that, be able to not only make some statutory changes if necessary, but also start to look at our entire crisis continuum as a bigger response, more opportunity for folks, because we do know that at times inpatient is not always available. And so CRSS could be an answer for that. So we are having those conversations very much at the beginning and welcome any feedback or ideas around that from anyone in the audience or from our provider network.
Okay, thank you. We will now break for lunch, but please be back at 1 o'clock because you do not want to miss the Office of Medicaid Policy and Planning. And someone will get you a note card to write down your question. Questions will be answered at the end of the presentation.
Good afternoon, and thank you for being here today. My name is Lindsay Lux. I'm the Deputy Director and Chief of Staff for Indiana Medicaid. You're going to hear from several of our team members today, and I will introduce them as I run through our agenda. As you know, the Medicaid budget is divided into two separate budgets. The first is Medicaid assistance, and that covers the medical benefits. The second is administration, covering the operating costs for the Medicaid program. Medicaid assistance will be covered by Kathy Leonard, our Director of Reimbursement and Actuarial Services. Next, we have Katrina Etter. She is our Director of Clinical Operations, and she will be covering a deeper dive into home health, as well as covering the Pregnancy Promise Program, as Elizabeth is out ill today. Next, we have Medicaid has been awarded a CMS grant. That grant is to support us in our planning purposes, to come into compliance with the Juvenile Justice Consolidated Appropriations Act. Larisha Ratliff, our Director of Government Affairs, will present that to you, and I will finish up with that second Medicaid budget of administration. At this time, I'll turn it over to Kathy Leonard.
All right, thank you, Lindsay. So before we get into the quarterly results, we wanted to start today with a little activity. Audience participation opportunity here. And this is something we had done a few years ago within our Medicaid team. We framed it up as who wants to be a Medicaid millionaire, and then how you might spend that money. But we thought it would be something good to review with this broader group today. So again, the idea is, what if you went on Who Wants to Be a Medicaid Millionaire and you won? You won $1 million. And that could be used for any type of Medicaid expenditures. How would you decide how to spend that money? What can you actually buy with $1 million? So if we started with, and this is where we're going to do a little math together. Who are the math people here? We're going to do a little air math today. So if you started with, well, what about children? right? Children, they're our future. They cost about $260 a month under Hoosier Health-Wise, but a little more with additional benefits. So let's say close to $300. So how many children could you cover for a year with $1 million? So if you say 300 a month, 3,600, you multiply that out, it's a little less than 300 children. So 288 healthy children could be covered a year under Hoosier Health-Wise. So you'll see there 288 H's. H stands for, of course, Hoosiers. We don't have a big graphic budget here in the Medicaid team, so this is homemade. So 288 healthy children. So what would be some other options? What if you said instead, what about the Healthy Indiana plan? I want to cover adults. Do adults cost more than children or less? They cost more. When you add everything up, for a HIP, it runs close to $800 a month. So if you switched over to HIP, you could cover 102 healthy adults. Another option would be if you wanted to look at Hoosier Care Connect, the blind and disabled population under age 60. They have more medical needs, so they're going to cost more than you would pay for healthy adults and children. So if we were to look at that program, it would drop down to 58 Hoosiers could be covered under that program, adults and children. But what about our Pathways program, Pathways for Aging? What if we say we want to look at those Pathways waiver members? These are individuals who qualify for a nursing facility level of care, but they're receiving care in the community. How many could we cover? Well, it depends on whether they are dual or non-dual. So we could cover 18 Pathways waiver members if they also have Medicare coverage. But you can see it drops off quite a bit if Medicaid is paying the whole cost, so 10 for non-duals. And then last but not least, what about nursing facility residents? And again, we have two answers there. One if they have Medicare coverage and one if they do not. So these again are just some sample choices. There are many other populations, but if you look across and say, look at these varied choices, it would be a difficult decision if it was up to you to say, how do I want to spend that $1 million knowing the other individuals would not receive coverage? And so we wanted to bring this up, as an exercise today because these are the types of decisions that we face as we're going forward, looking at managing the Medicaid budget over time. And one of the things you can expect in future meetings is more emphasis on specific populations and how much they cost so that we can have higher awareness of this.
So Kathy, if I may, just for those in the audience, we have the dual program and rather the Pathways program is for 60, right? 65 is where you hit Medicare, right? So you would think everybody would be in Medicare. Unfortunately, that's not true. As everybody up there knows, and Paul knows, we have about 10,000 people, I believe the number is about 10,000 people, who are over the age of 65 and not on Medicare. So one of our big efforts this year, calendar year and fiscal year, will be to move as many as we possibly can, individuals who are over the age of 65, onto Medicare, because as you can see from this chart that Kathy was kind enough to create, you can certainly serve far more people as a dual than as a non-dual.
Thank you. So anyway, this is just intended to be food for thought, and I believe actually our later presentation today, we're going to hear some from the DDRS team about different population costs. So you can expect to see more of that in the future. So now back to our sort of regularly scheduled review program here. So today we'll be talking about enrollment and expenditures under the Medicaid program and comparing it to the forecast. And the forecast was presented in April of this year. And when we look at enrollment, we're showing that the enrollment for this quarter, July, August, and September, is 12% less than forecast. Now, the primary reason for that is that when we set the forecast, we expected to have some very slight growth, almost flat, but our enrollment had been fairly flat the prior 9 months. So we had forecasted flat. And what we've been seeing since the spring is some continued declines in enrollment, so about 2% a month. So when you expect it to be flat and you're seeing declines, then you're going to see after 6 months of that, some pretty big differentials there in terms of the enrollment. So overall for the quarter, our enrollment is 12% less than what was included in the forecast. And usually you expect expenditures to move in the same direction. So it shouldn't be a surprise that expenditures are also coming in about the same level below the forecast as well. So if we go into a little more detail around the enrollment, the biggest enrollment differentials we're seeing, this is for the managed care programs. The biggest differentials to forecast are for the HIP program and Hoosier Healthwise. Those are both coming in at double digits below the forecast. Pathways is slightly below. Hoosier Care Connect is aligning much better. But these enrollment decreases are due to some changes in the way that we're doing our Medicaid redetermination, where we're requiring more information to be submitted, and that was started in March. So we expect to see some of these declines continue, but this is the result that we're seeing for this particular quarter, that most of the programs have less enrollment than we had forecast. If we switch over to the fee-for-service population, this is another population where we're seeing significantly below forecast. This one is showing 18.9% below forecast. The dynamics of this are a little different. Some of the differential is due to some retroactivity we have to some of these programs, and part of it is also due to declines that we are seeing under very specific populations. The HIP emergency only and limited benefit populations, we had not forecast those drops. They don't have as much impact as the managed care decreases because those are less expensive populations. But overall, we're looking at enrollment 12% below the forecast. So now we're going to switch over and talk a little bit about expenditures. And so if you look on the right-hand side, the variance that we're showing is that for expenditures in total, we're coming in $240 million or 11% better than the forecast. And so usually we look at that shaded column of the variance and see which ones are in the black and in the red. And so you can see managed care, fee-for-service, and our other expenditures and collections are all doing much better than forecast. The manual expenditures are one area where we're coming in with a spend much higher than forecast. And those are primarily some of our special subsidy programs, so we'll give a little more detail on that. But overall, we're looking at expenditures much better than forecast. If we look in more detail at managed care, again, you can see most of the programs are showing a positive variance to forecast. The expenditures in total are about 6% better than forecast. HIP and Hoosier Healthwise, as you can expect, with the enrollment being significantly lower, their expenditures are going to be lower because these are capitated payments. We only see one program that is showing in the red, in the variance, and that has to do with some managed care quality payments that were made in July and had been forecast to be made in June. So they're showing up in this fiscal year instead of the prior fiscal year. And so that's the main difference we have there in the managed care expenditures. When we shift over to fee-for-service, at the top you can see in total, the results are coming in $100 million better than the forecast, about 7% better than the forecast. We are seeing positive results in most areas. The waiver services in total is showing very positive forecasts, as well as the fee-for-service state program. There are a few areas that are showing up in red. One of the waiver programs, the Family Supports Waiver, is one that is showing a little higher, and there's some specific areas, services, participant assistance and rehabilitation, and we are collaborating with the waiver team to look at whether there are some mitigation actions we need to take on those. But by and large, the results are very positive. One of the areas that's contributing the most to the positive variance is that the attendant care services expenditures are coming in much better than forecast, and that is due to a lot of work around utilization management. So again, across the board, fairly positive results. So our next category, other expenditures and collections, and this is mainly collections, and most of the time it is dominated by the pharmacy rebates. But you'll see here pharmacy rebates are coming in better than forecast, as well as some payments related to Medicare and Medicare clawback. So across the board here, again, we are seeing fairly positive results. So as mentioned earlier, we do have one category where expenditures are coming in significantly higher than forecast. And these are manual expenditures, which are mainly subsidy programs. So the biggest driver here is our DISH subsidy program. And this is really a timing issue where we were asked to make some early payments sooner than we had forecasted them. So you'll see that the DISH payments are showing as $190,000 higher than expected. And that's just a timing issue. So we'll have a future month where those payments are much lower than expected. We also see other supplemental payments, the nursing facility and ambulance payments that are coming in higher. And some of that has to do with speeding up the payments of some of those items. But again, these are primarily things that are funded via physician or provider payments. So it isn't something that would be a negative impact in terms of the state forecast numbers. So I want to turn to a few of our watch areas. The first one we've already discussed a little, and that is we've been keeping a close eye on the Hoosier HealthWise and HIP membership. And you can see from the arrows, right, they started coming down in April, right? Just as soon as we announced that forecast and said it'll be flat, they started to come down, right? That's how it works sometimes. But I think the one thing that is notable here is that for the month of September, we saw a much smaller decline than the other months. So when we had first done our redetermination after the public health emergency, we saw more activity in the first 6 months, and it slowed down a little bit, because one of the biggest questions we have is how much will that continue into the future, and what are we looking at for the future? So this is one area we're continuing to look at. Another watch area that we've discussed every month and every quarter is the ABA therapy. And we continue to see a growth in the managed care ABA therapy recipients. So you'll see on the left-hand side, the green line represents managed care. So 20% year-over-year growth in recipients, and we're seeing the same on the expenditure side as well. So those trends are, an area that is a concern, and we do have, there's a work group, a broad stakeholder work group that's going to be announcing some recommendations for the future, but the trends are continuing at the same pace that they have for some time now. Now, the next slide, this is actually some new data we hadn't presented previously, and some of you may be looking at the chart and saying, I think I've seen that chart before. But what you've seen is, this is a chart for attendant care services. What we've shown in the past has been for our fee-for-service program. And this is the first time that we're showing data for our Pathways for Aging program. So for those of you who may not have seen this before, this is a chart showing the recipients of attendant care services, and it's stratified. And so the different colors, if you start at the bottom, the dark blue are recipients that are receiving less than 20 hours of service a week. And then the orange is 20 to 40. The green is 40 to 60. And then the brighter blue is 60 or more hours a week. So when we look at this chart, we're seeing a flat number of recipients. It's slightly up, but it's fairly flat. But the bright blue at the top is what we really look at the most, because those are the higher utilizers. And so the positive news that we have here is this is the first year of pathways. And in July, the percentage of users that were receiving 60 or more hours a week was 16%. And by the end of the year, June, that had dropped down to 7%. So that's a good thing to see that bright blue segment getting smaller. Now, one thing that you can't see in this slide, but is another positive thing, is that the average hours of service for that bright blue category, it dropped from 90 hours at the beginning of the year down to 82. So that's another positive thing. So it's less people in that category, and they're also receiving, on average, less services. So kudos to the Pathways MCEs. A lot of work has gone into managing these costs. And I do want to note that 82 hours a week is still a lot, right? If you multiply it out on an annualized basis, that's $150,000 a year on attendant care. So I think there is still opportunity here in terms of, improving in that area as well. And then the last slide is, instead of the recipients, these are the expenditures. So when you look at the expenditures, again, you can see that impact of less individuals and less hours for that group. So that's a positive trend line. One caveat that I do want to note is, even though these results are very encouraging, we are noticing some increases in the home health expenditures, both for pathways and fee-for-service. And some of it does seem to be related to individuals who are receiving both. And so we want to make sure if there's any shifting going on, it's because it's the most appropriate thing, but we do have to look at things in total. And my colleague, Kat Eder, is going to speak a little bit about home health a little bit, but that is one of the things we're looking at as well. So, no, I guess it's not even a little bit, it's right now. Let me turn this right over. You don't have to wait.
All right. Our clinical operations presentation will look more closely at our home health benefit. We'll also do a Medicaid managed care quality update and a financial update on our pregnancy promise program. So I'm going to present a closer look at one of our Medicaid covered benefits, which is home health. The home health benefit is covered under our state plan, and it does include skilled nursing, home health aid services, and skilled therapy. Skilled therapy can be further broken down into PT, OT, and ST. There are other services that members may receive in the home that fall under our waivers. They can often get confused with our state plan home health benefits, such as attendant care, respite care, but it's important to note that those services are separate from our state plan home health benefit. So in an effort of ongoing transparency, we would like to dig a little further into the breakdown of expenditures for home health over our most recent state fiscal year 2025. So the next slide will show which programs are driving the largest home health expenditures for our Medicaid populations. So in state fiscal year 2025, we had close to $490 million of total spend for our home health benefit. This slide gives a little bit more insight into which programs are driving the largest proportions of that total spend. Fee-for-service accounted for 67% of that total spend, and Pathways accounted for 29% of that spend. So combined, those two programs account for about 96% of the total home health spend, and the remaining programs contributed very small percentages of that total. State fiscal year 25 did see an increase in total spend for home health of approximately $130 million from state fiscal year 2024. As we continue to monitor trends in this space, we also wanted to see how total expenditures trended quarter over quarter, both pre and post pathways go live. So the next slide will look at that a little bit more. So Q1 and Q2 2024 shows that home health expenditures for fee-for-service, which was prior to Pathways Go Live. Following Pathways Go Live, the chart on the slide adds the expenditures for the Pathways program in orange, which shows the total spend for both Pathways and fee-for-service combined. The annualized growth rate of expenditures for fee-for-service is about 32%. Pathways is about 50%. The recipient annualized growth rate, which is essentially the increase in unique members for each program that are receiving the home health services, was 24% for fee-for-service and 14% for Pathways. So taking a closer look, we're seeing two different contributing factors between the two programs for the spend increases. Fee-for-service is driven more by an increase in members receiving the home health services than Pathways. Pathways appears to be driven more by utilization. So a review of the data at this point is pointing towards increased utilization in Pathways due to increased hours per recipient versus a higher percentage of higher cost services for home health. The further data analysis, which is underway, is going to continue to provide more insight to cost drivers for this benefit. But tying this piece of the presentation a bit back to Kathy's watch areas, we know that we have members that are receiving both home health services under the state plan as well as waiver services like attendant care. So when we're looking at those areas of overlap, it appears that the people who are receiving both are getting less attendant care, but are trending upwards in the home health care utilization. We're still seeing a net overall savings when we're combining the two areas, but understanding that shift in utilization is key to understanding the changes in the future cost drivers in the space. Shifting gears a bit, we'll look at quality in Medicaid. As a reminder from the last QFR presentation, we do contract with 6 MCEs, manages our 4 programs, HIP Hoosier HealthWise, Hoosier Care Connect, and Indiana Pathways for Aging. We continue to be committed to ensuring transparency and accountability for the quality of services that our members are receiving. At the last QFR, we did present the 2024 NCQA MCE STARS ratings, which covered the MCE's quality performance for measurement year of 2023. The 2025 NCQA STARS ratings were recently released, which cover the measurement year of 2024. So we'll be providing an update on where our MCEs are standing for this measurement year of 2024, and also a look back at how they're trending in their quality performance. The 2025 STARS ratings will reflect the H programs only at this time, given that we did not have a full measurement year of Pathways for 2024, but Pathways should be included in the 2026 NCQA STARS ratings, and we will cover that measurement year at the QFR. At the prior QFR, we did provide some background on MCE requirements for NCQA accreditation, but as a reminder, all of our MCEs are required to maintain accreditation with NCQA. The MCEs have to submit HEDIS and CAPS data to NCQA annually, and that data is used by NCQA to determine the plan's quality ratings, which we refer to as the STARS ratings. So this slide displays the NCQA plan star ratings as of the 2025 report, which reflects data for the calendar year of 2024 for 5 of our 6 MCEs who are managing the H programs. The 6th MCE, Humana, does not yet have an NCQA star rating for Indiana Medicaid because they entered our market in 2024 for Pathways. The STARS ratings are on a 1 to 5 scale. 5 is the highest and 1 is the lowest, and they're rounded to the nearest half point. So what does this mean and how do we compare to other states? The MCs are ranging between a 3 and a 4 star as of the 2025 report, which is the same range as 2024. We would consider MedWise a low average with 3 stars. CareSource, MHS, and Anthem average at 3.5 stars, and United is above average at 4 stars. At an overall average of 3.5 stars, we can say that our MCEs cumulatively on average are performing between the 50th and 66th percentile compared to the Medicaid health plans nationally. A 5-star rating, again, is the top 10th percentile. It's very hard to achieve. Only about 1% of health plans nationally do achieve that. And we do not currently in the nation have any Medicaid health plans with a 5-star rating. In the 2025 NCQA STARS report, 48 of 212 Medicaid health plans did receive a 4-star rating, one of which was United Healthcare, which is our highest. This slide shows some additional detail on how the MCs have performed over time. The chart is looking at the reported years of 2023 to 2025. That covers our measurement years of 22 to 24. You will see that 2023 is missing a bar. So for report year 2023, United did not have data for Indiana Medicaid because they were a new plan for our Hoosier Care Connect and we're undergoing that NCQA accreditation. So how have the MCEs trended over time on their quality performance? Directionally, MHS has not trended up or down, but has remained constant at a 3.5 star. CareSource has improved from 2023 at a 3-star to 3.5 stars in both 2024 and 25. And United has improved from a 3.5 star last year to this year's 4-star. So we do commend United Healthcare on achieving the highest stars rating amongst our MCEs and improving performance from last year as well. 2 of our MCEs have shown some downward trends. Anthem was our consistent highest achiever with 4 stars for 2023 and 2024, unfortunately has now dropped to a 3.5 star in the 2025 report. And MedWise fell from a 3.5 star in 2023 to consistently performing below the other MCEs in 24 and 25 at a 3-star rating. So as the state, we will continue to strategize on ways that we can encourage high quality performance amongst our health plans and incentivize that performance. So in future years, we're looking at incorporating the STARS ratings into our P for O's, or our payment for outcomes, which will formally incentivize the high performance that we expect from the health plans through financial incentives as well. We believe that quality is intrinsic to the Medicaid program's performance. We'll continue to provide transparent updates in this area. The last topic for our clinical presentation is an update on Pregnancy Promise. So our Pregnancy Promise program is available to pregnant and postpartum managed care members, as well as their infants who are impacted by substance use disorders. And the program operates across all 92 counties in the state of Indiana and is funded wholly by federal grant dollars through CMS and SAMHSA. As of September 30th, the program has served about 1,500 mothers that have been impacted by SUD and about 1,175 infants. And there are many participants in the program that are currently pregnant as well. This slide reflects the program operating costs, which includes the FSSA staff. So there is a program manager, a program specialist, as well as a contracted data scientist. There is an additional 1.0 FTE position that is budgeted with the grant dollars, and that is currently not filled. The external services expense category is primarily comprised of the MCE contracts, which are the service delivery partners for the program. Additional operating costs and administrative expenses do include things like program materials, in-state travel, data infrastructure resources. The slide does indicate that the program is underspent at this time, but we do anticipate that that will change in future quarters as there was a timing delay in increasing or in executing our contract amendments as of July 1st of 2025.
Good afternoon, and as stated, I'm Larisha Ratliff, and I'll be talking to you about the Juvenile Justice Consolidated Appropriation Act, our implementation plan and requirements. I'll do an overview, and then talk through the timeline, and then the budget and spend summary for the grant we received to do implementation. So FSSA was awarded a grant within Section 206 of the Consolidated Appropriations Act of 2023. We received this grant August the 11th of 2025, and that grant is to help promote continuity of care to justice-involved Hoosiers through the age of 21 and those who were previously in foster care through the age of 26. This is not a wide net of every youth, but they do have to have Medicaid at the time of incarceration and have a suspended status. So it's not every youth that gets incarcerated. Just wanted to make that clear. We were awarded $1.3 million for the first year. It is a 4-year grant that will total $4.2 million. It is a non-compete renewal, so each year with progress, we would get additional funding, depending on what's happening with the government and all that. The grant funds cannot be used to cover the actual cost of providing the service itself, but the grant can be used to build infrastructure, anything related to partnerships, data integration, anything like that, but we cannot use the money to cover paying for the actual services. The services that we must provide are EPSDT, that is early and periodic screening and diagnostic screenings, and we have to provide the targeted case management. And they would get that 30 days before release, and then the targeted case management 30 days after release. And so moving to the chart, we've taken like a look at what this would cost. I'll talk here shortly about the phased approach. But looking at just our DOC partners, and that's who we're partnering with for phase 1. For EPSDT, the year 1 estimated costs were about $104,000. For targeted case management, we were at about $124,000. And then for total, it was about $228,000. Again, the average Medicaid members that would fit in this bucket was 328. When we look at the cumulative federal and state match, for federal, it was 65%, state 35%, and then the dollar amount there for the match would be $148,000 for federal, and then the around $80,000 for the state, giving us a total expense of $228,531. And again, just keeping in mind, this is just for the DOC rollout. So when we look at phase 1, what are we working on? Since August, we have, prior to the grant, established an interagency work group. That work group entails DMHA, we have DFR, we have OMPP sections, and we also are looking to add our BEADS partner to the mix to look at the transitions between youth. We have also worked with WISE in conducting a survey. The survey is not complete, but we're working on getting a survey to get additional input from stakeholders to understand barriers and care coordination needs. We are looking to hire a reentry coordinator who will help us really implement this and help us make sure we are meeting our milestone goals. And then we have worked on not really having it crystal clear, but looking at what requirements we're going to need for that data infrastructure and what things do we need to have in place to build out and really receive files from additional facilities outside of DOC. And so once we get that survey completed, we are looking to get that out and spread a wide net. We're hoping in December, early December, to have 2 webinars to really talk in a little bit more detail about the process, and then we will provide additional information in regards to that. But our focus in phase 1 has really been on the DOC initial rollout, and we're hoping to get that started January 1st of 2026. In phase 2, it's going to be a state rollout. We're going to look at adding additional juvenile facilities, and we will look at that from July 2026 through June of 28, to get to the statewide status. In phase 3, we're going to look at sustainability and really just optimizing our transitions and operations. And again, just to jump back to phase two, we're looking at what recommendations we can make from the data we have to look at what will work for our state for future sustainability. When we look at the grant funding that we received in personnel, we have 2,482 so far. That's inclusive of our state staff, and we have not been able to hire yet, so it will increase as we hire that position that we're looking to fill. So the actual spend is the 2,482, but the budgeted was 6,859, just that 4,000 variance. For the external services expenses, that's going to be our data changes, any changes we might need to make to core. We haven't yet finalized cost on some of that, so you don't see expenditure there. It's going to be some of our project management that we have not seen invoices for. So as we get further in the implementation, we'll definitely see more utilization of the funds. And so I will skip down just to the funding. Like I said, overall, you see light utilization, but it's just as we're getting rolling, we have not seen a lot of the money come through yet. But we are scheduled to utilize in the grant year one, the $1.2 million, and we were budgeted for 1.3. We can definitely make adjustments as needed to some of our asks and put in requests, but that is where we are right now. And I will pass it over to Lindsay.
Thank you. I will run through the Medicaid administration budget at this time. The Office of Medicaid Policy and Planning spends less than 1% of our total Medicaid spend on administrative costs to operate the program. In general, costs incurred by states are matched at the federal government level at 50%. There are a few categories where our funding is matched at a higher rate. Those appear here. These do require CMS approval, primarily through their APD or advanced planning document process. Our current run rate is 70% federal and 30% state dollars, which is excellent. This chart represents state fiscal year 26 expenditures year to date. As you can see, the majority of our expense is in contracts at 87%. Next, we have staff salary and benefits at 8%, and 5% is spent on other admin operating costs, such as state admin allocations and mailings. This slide shows our admin budget by spend type and funding source. You'll note in personnel services, we do have a variance. This is due to a 10% increase in employee health insurance that will be experienced during the state fiscal year, being absorbed by the state for employees. However, we will be able to make this up during the fiscal year and probably as early as next month. Next are contracts or external services expense here. Year to date, we have a positive variance of $9 million. This is due solely to a lag in vendor invoicing. We expect vendors to catch up with that and absorb that surplus soon. The negative overall surplus in this line is due to additional scope built into contracts as a result of executive orders and federal requirements. The provider application fees are all a net positive to the state. Those are fees that providers pay to enroll in Indiana Medicaid and are used to offset other admin expense. The IoT expense here, we see a variance. This will likely flesh out over the year as well. We budgeted during quarter one of 26 a little less than what we're seeing those increases be. So if you look in our funding slide, you'll see that we do have about a $2 million shortfall. It is nearly all in that contracts line. You can also see that it's about 57% federal. So we have around $800,000 that we will be working to make up throughout the year. Next is our staffing. During the month of September, we had 110 employees at the Office of Medicaid Policy and Planning. We have added a couple since and are continuing to work on filling our vacant positions. Finally, here are our major administration contracts. You will see that Gainwell is our largest expense. Gainwell serves as the state's fiscal agent, fee-for-service claims payer, and MMIS system operator. You'll also note that Optum Government Solutions appears twice for data warehousing. These contracts are managed by the FSSA Data and Analytics team. The duplication is solely due to the timing of procurements, and one of those contracts will term at the end of this year. You will also note in the Maximus level of care assessments line item, this contract is again paid for by Medicaid, managed by the Division of Disability, Aging, and Rehabilitative Services. We have not received any invoices this fiscal year on this contract, so that $9 million that we just saw, around $5 million of that will go here when we get those invoices in as well. So we are also reconciling invoices with the other vendors where we have no year-to-date expenditures, Myers and Stauffer and Deloitte, our new actuary. That concludes our presentation. Again, thank you for being here with us, and at this time, we will take your questions.
Thank you, Lindsay.
My pleasure.
So were you here for the mental health discussion?
Yes.
Okay. So for those of you in the audience who are not, next time we do this in public, I would like to be able to discuss the totality of government's, of what this agency spends on mental health care and addiction services. So I know that's something that we've been working on. We probably ought to rehearse that once, like in I think the next one of these is in January 30th, I think is the date. I refused to allow Paul to do a monthly financial review after Christmas in December. He wanted to, but I just said, no, Paul, we're not doing that.
Come on, Paul.
So maybe just before Thanksgiving, we could at least try to roll something out on a rough basis to see before we take it for a ride in public.
Will do.
If anyone has any filled out note cards, if you could please hold those up. If not, we have no questions online, so thank you. We now will have a 15-minute break, and then we will have the Division of Disability, Aging, and Rehabilitative Services.
Thank you.
Good afternoon, and thank you for coming. Once you guys sit down, I'm gonna start calling out people's names. Thank you for coming to the Indiana Family and Social Services Administration's quarterly financial review. Now we have the Division of Disability, Aging, and Rehabilitative Services.
Thank you, Marcus. Good afternoon, everyone. I'm Kelly Mitchell. I currently serve as the Director for the Division of Disability, Aging, and Rehabilitative Services. If you would, go ahead and skip to our agenda for the day. I have with me here on the podium Kathy Robinson, who is the Associate Director for the division, and Stephen Gale, who is the Controller for the division. We'll be making the presentation today, and if you would, advance to the next slide. I would also like to recognize the division houses 4 bureaus. Each of those bureaus has an identified director, and they are with us here today in the front row. We chose not to put all of us up here. We thought it might be a little crowded. So we have with us the Bureau of Child Development Services Director, Christina Commons, our Bureau of Rehabilitation Services Director, Teresa Colazar, our Bureau of Disability Services Director, Holly Wemsat, and then our Bureau of Better Aging Director, Aaron Wright. So you might likely see me defer to them if there's a question that's a little more in the weeds, to which I would be familiar. We have presented before, but as we've stated, the division is comprised of 4 bureaus. We serve individuals with disabilities and as they age across the lifespan, from birth or cradle, if you will, to grave. The Bureau of Child Development Services, their biggest program at present is First Steps, focusing on early intervention services for children birth up to 3 years of age. Our Bureau of Rehabilitative Services is focused heavily on vocational outcomes through our vocational rehabilitation services, but also houses within deaf and hard of hearing services, as well as blind and visual impairment services. And they are the liaison for our centers for independent living. And then our Bureau of Disability Services provides services for children and adults with disabilities, all disabilities, in home and community-based services, either through Medicaid waiver or supervised group living, sometimes referred to as group homes. And then our Bureau of Better Aging is the identified state unit on aging, supports our aging and disability resource centers and provides services and supports to Hoosiers as they age, as well as individuals with disabilities. Next, please. So we're going to speak a little bit of our Bureau of Child Development Services, in particular, Indiana's First Step system. What you see in front of you are maps that give an overview of the children and families that are supported through First Steps. First Steps is a coordinated system. It's across all 92 counties within the state, and it is there to ensure that infants, toddlers, and their families are supported in a timely and effective manner. If you look at the first map on the left, this is just a total number of the children served during this first quarter of the fiscal year by county. I will note, if you see a county that has a blank, that would be an instance where the number of children and families supported is under 10. So to protect privacy, we do not provide that particular information on this public graphic. And then in map 2, you will see percentages referenced. So I would like to make clear that that would be the percentage of the total number of children served. It's not of the county, but of the children served by First Step who are at or below, who are at 250% or below of the federal poverty level. We reference that because I think that gives you a good idea of the demographics and really the broad range and array of individuals that we support. I would also note that First Steps is a federal entitlement program. I'm providing that as some background, as you will see not only how we provide services, but also how those services are funded. That might give you some insights. What you see in front of you is some basic information on the numbers of children and families served, some of the trends that we have been witnessing, not only in this first quarter, but over a period of years. As I stated, the program is available across the state. We have 9 local regional offices that provide service coordination and eligibility determination. We have 43 provider agencies who have agreements to provide individualized family service plans, or we refer to that as an IFSP. And those entities employ or contract with approximately 1,800 early intervention providers. We also have about 100 independent providers in the network who provide nutrition, social work, audiology, vision and psychology services, as well as interpreter services. You will look in this upper right-hand corner from state fiscal year 22 through the state fiscal year that we just concluded, state fiscal year 25. The First Steps program saw a 22% increase in the number of children served. And that means that they had or have an individualized family service plan. So when we say served, it wasn't just the child or family was referred and they were assessed, but they actually had a plan of services. Also, during this first quarter of state fiscal year 26, First Steps has already received 8,300 referrals. You see that in the mid row on the left. And we have served 17,023 children state fiscal year to date. I also think it's important to note the number of completed family visits. First Steps is a home and community-based service. It is meant to be provided and supported in what we refer to as a typical or natural environment. So it's focused on supporting the family in acquiring the skill set to support their child in those developmental milestones, as well as providing the therapeutic services. So over 193 visits in this first quarter of the current fiscal year. I would note if you look in the lower corner here, we receive referrals from multiple places. But our top referral source does include physicians and healthcare professionals, as one might imagine, and parents in seeking those services. Okay. Christina, I'm looking at you. I probably should hit the exit data. Let me go back because I'm thinking I wanted to talk a little bit about that. So if you look in this lower corner, there's some data here for the first quarter, and I hope to explain this eloquently. So you'll see the dark blue metric there is the number of children who exited First Step services without an IFSP. So meaning they were referred, they may have gone through assessment, but never pursued services. The plan of services was never completed. So you'll see that actually stays pretty static, each month, around 1,400, give or take. Then you'll see the lighter blue color. That is the number of children that exit with an IFSP. So they had a plan of service and they've exited. And again, kind of static. You'll see a little bit of a dip there, if you will, in September, but around 1,000, 1,200. But the numbers that we're most interested in are these last two, the orange and I'm going to call that purple. The number of children that are transitioning to school, which is what we want to see. The children are moving on to school, so around 400 or 500 each month. And then the number of children who exit with outcomes met, meaning they achieve those developmental milestones, those goals that were identified within the individualized family service plan. And so that's around 300 each month. And those are the numbers that we're keenly interested in. We'll continue to work on how we display this metric because those are kind of subsets, if you will, of that larger number of, children that exit with an IFSP. So we'll continue to kind of ferret that out in future public presentations. Thank you, Kathy.
Sure.
Sorry, made you back up just a little bit. You've seen this data before. This is an area that I want to continue to highlight. I referenced the diversity, if you will, of the population that we serve because this is an entitlement service. It's not based on income. need. It is based on eligibility of the child being found to have a developmental delay, risk of delay, and in need of services. So it allows us to implement, I think, some very innovative approaches to funding those services. And I will say, I will boast on Indiana, I think we lead the nation, I think, in this approach, and we are looked at by other states as a model as to how they might manage their first steps in early intervention services. So what you see in this, in the top corner on the left-hand side are just the service claims cost month by month. And then you will see some of the sources that we, and I'm going to say chase, because we truly do use a pay and chase model. Each year, the legislature appropriates to our Bureau of Child Development Services, or First Steps, state dollars. So we utilize those to pay for those service claims as they are submitted each month. But then we chase the appropriate funding source. So if the child would be Medicaid eligible, we would seek Medicaid recoupment, but the state does that through our system, rather than saying, if you're Medicaid eligible, use Medicaid first and not the First Steps dollars. If the family has private insurance, we pursue recoupment through that private insurance company. And we, the state, are the ones that are seeking that recoupment. And then also families, based on their income, do pay the family cost participation. And so that is assessed, and you will see that we've seen some improved trending in those collections. You're going to see highs and lows because of that pay and chase model. It won't always directly align month to month with the service claims cost, because obviously there would be a delay. Service provided, claim submitted, state pays, then we chase the recoupment. But what we are most pleased with is we have continued to see an upward trend in our recoupment of private insurance funding for those services.
So at some point, we were having some issues with the treasurer's office and their system there, and Jason Johnson in the governor's office was kind enough to hopefully help us intervene there. Has that been resolved?
Christina? I can answer, but she can do it much more eloquently than I.
That's still in process, but I think we have found out that the majority of those funds are making it to our account.
Yeah, there's been some interesting challenges because as a state, we have one EIN, and so we have different agencies and divisions within the state that are billing. So it's been interesting, to say the least. Next slide. And Steve, I'm going to let you speak to the financials.
All right, thank you. Here in our financial report, as you can see that in the year-to-date expenditures for the actual column, we've spent a little over $18 million so far through the first 3 months of the state fiscal year. And we had budgeted up to that point for $20.5 million. So we're a little bit below what we had budgeted, but we're not in any main concern about that yet. The two areas that I'd most like to highlight is in the external services expenses, or the contract services line item, where you see a variance of almost $1 million. It appears that we've overspent what was budgeted to that point. That actually has come down each month. And what we've seen is some of the contractors had front-loaded what they were claiming, and we anticipate that variance amount is going to continue to decrease as time goes on, and we'll eventually anticipate to be hitting right at budget. And the other line item I wanted to point out is the social services payments. This goes back to what Kelly was just talking about with the recoupments and the service claims, that kind of varies from month to month a little bit. It looks like that we are way under budget on that one by about $3.3 million. But again, we're not too concerned about that at this point. We just know that there's going to be fluctuations in the amount of recoupments we receive from month to month. So we think that's also going to play out and be really close to what we've budgeted to as the year goes on.
Thank you, Steve. Also, before we move on, near the conclusion of our presentation, you will see a slide that talks about our initiatives, kind of future state, where we're putting our focus, but I really do want to highlight those as we move through each of the bureaus. So I discussed and mentioned that success that we're having with the private insurance, or that third-party recoupment, if you will. First Steps is continuing to look at how to improve that process, working with our vendor PCG. Part of that is that we're looking at how do we better utilize data, refine our data collection. Many of you, if you are working with us, partnering with us as providers, know that we have been making improvements to EI Hub, which is our client services claim management operating system that just gives us an improved lens and more timely access to what is actually occurring. That allows us, I think, to pivot more quickly to inform our strategy and decision-making as to how do we better approach service delivery and funding those services. Next, we're going to move on to our Bureau of Rehabilitation Services. Again, you will see on the left side of this a map that highlights the number of open VR cases by county. So this is numeric, not a percentage. So these are the numbers that are served through our Office of Vocational Rehabilitation by county. They have an open case, meaning they've applied and they're somewhere in the process. I would note that the Bureau of Rehabilitation Services maintains a central office, and we do have 19 different field offices throughout the state. And we serve over 30,000 individuals with disabilities each year. It gives you a little bit of a reflection of each of the bureaus housed within the Bureau of Rehabilitation Services, the largest one being Voc Rehab. The focus of Voc Rehab is to assist eligible individuals regardless of disability type, can be physical, mental impairment, to prepare for, obtain, maintain, or regain, if you will, and advance in employment. We've put a particular emphasis on this. I think you're all aware, at not only the state level, but a federal level, a renewed interest in employment. I think adding to the quality of life. We also know that historically, individuals with disabilities are underemployed as compared to the rest of the population. So really looking at how do we leverage that federal funding source and the services that are supported therein to improve outcomes for individuals with disabilities in the area of competitive integrated employment. We also have the blind and visual impairment services. We support a great deal of entrepreneurial opportunities for blind Hoosiers, as well as services that support independent living for older blind Hoosiers, so that 55-plus population. And then our deaf and hard of hearing services certifies interpreters in the state of Indiana, as well as providing case management services to improve independent living skills of deaf and hard of hearing Hoosiers. What you see in this lower right corner then, and I think, Kathy, or no, it was Lindsay in the OMPP presentation was talking about the leveraging of federal versus state funds and other revenue sources. So we do see what we do in BRS is extremely cost effective. You will see that 76% of the funding leveraged is federal, 21% is state, and we do use a great deal of that, almost all of it, if you will, to match, to draw down those federal dollars. And then we do generate some revenue through our blind and visually impaired services when we talked about those entrepreneurial efforts. So there's some self-generated.
So are we maximizing the amount of federal money we can pull down?
Secretary Rowe, I'm so glad that you asked that. No, we are not. We are not maximizing all the dollars that we can pull down. I will say, and kudos to Teresa and the team, actually the entire FSSA team, we were able to leverage a few additional dollars this year, working within DDRS to draw down some additional federal match, but we did leave a great deal on the table. We've spoken about some of those future opportunities, and Teresa knows I've really been leaning into really how do we maybe partner with our associates in Division of Family Resources and supporting people in finding employment and maybe better leveraging those federal dollars.
So this is a new question, which I've not asked before.
Oh, okay.
And I don't need an answer today, but maybe in November, we could have a slide on how are we, or are we not, interfacing with the deaf school and the blind school. I simply don't know that answer. I drive by them each on occasion, and they're completely, I wouldn't know who to call at one of those schools if I needed to.
Yes.
Right? So that's for November.
We will take that one away and we'll prepare for the next. Okay. Next slide, please. Oh, good. I was like, wait a minute, did I lose?
Sorry.
So you're going to see some data in front of you that really is just kind of, we're trying to demonstrate graphically some of the trends that we are seeing. You will notice that we've, continued to have program growth. So the number of individuals that we are supporting has continued to trend up. We have seen, and we'll talk about this throughout, a little bit of a leveling in that growth, but particularly post-COVID or post-pandemic, we saw some pretty significant and steady growth in numbers served and enrollment. So then that also then has an impact on our service expense trends, and you see those highlighted as well. I talked about future state, but this is also current state. Teresa Colazar, as director and her team, have really worked significantly with our partners to find innovative approaches to sustain services and continue to serve as many individuals as we possibly can within the pool of funds that we have available. So there have been, some modifications to service structures and cost structures in order to effectuate that, and those have been regularly communicated publicly and to our provider network. Most of the population that is served through vocational rehabilitation are those with the most significant disabilities. Our most common primary diagnosis or impairment is intellectual and developmental disability, and then that is followed by mental health diagnosis, and then physical and sensory disabilities, if you will. We have kind of pulled back in, if you will, on outreach just because of some of the limitations. When we talked about some of those innovative approaches, one of those has been we aren't filling all of our vacant positions. We are working to be as efficient as we possibly can be without impacting service delivery. So we are leaning into the front line, our vocational rehabilitation counselors, keeping those positions filled, but looking at where can we find economies of scale, within the existing structure. So we will continue to do that as we move through the year and navigate the landscape. I don't think, is there anything you think I should highlight there, Kathy, that I missed? Teresa, did I miss anything? Okay. We'll move to the next slide then. This really is a breakdown, if you will, of the VR direct services expense by category. So if you look far left, this would be kind of overall. You will see that we provide a wide range of services to eligible individuals in order for them to achieve their planned employment goal. But our highest area of spend is employment services. And you see that on the left, and that's pretty significant. You know, one doesn't really have to read through that to see, hey, most of the spend is employment services. If you then move to the right, left to right, then we're breaking down those employment services, and you'll see that's a bit more balanced, if you will. This is one of the areas that the team has been successful, I think, in making some changes to better support the outcome of competitive integrated employment. So we've shifted, if you will, a higher portion of our funding to more direct job placement activities, and we've reduced as a portion, if you will, of the all, our spending on discovery and job exploration. So we've not eliminated those services, but really trying to redirect to say, look, the ultimate outcome here is we want people to have jobs. So leaning into those services. Secretary Robe, you looked as if you were going to ask a question. Okay. And then to the right, you will just see a breakdown, if you will. I'm not going to read through those, of those kind of employment service category spends. You can see the discovery and job exploration at the top. If you look at state fiscal year 25, discovery and job exploration was 38% of the overall employment services spend, as compared to state fiscal year to date 26. It's 22%. So we are seeing improvement in that particular area. And then drop down to the next blue line, you will see the spend is up as a percentage of the overall spend on employment services in that employment support and retention category. All right, we have some metrics here. I will highlight a few of those. I've already talked about the number of individuals that we support each year, but the number of VR applicants, if you look at state fiscal year 25, the monthly average was about 522. State fiscal year 26 to date, so for the first 3 months, we're at 1,511, so trending similar to what we saw the monthly average in 25. You will see total enrollment for state fiscal year 25 was 18,400. Year to date in 26, we're already at 14,247. I will try to kind of give a little bit of detail on these next few categories to give some insight. So the total number of VR cases closed for state fiscal year 25 averaged about 474 per month, so just slightly under 500. For the first 3 months of our current fiscal year, that we're at 1,829. So we are higher than, obviously, do some napkin math, that's a little more than 600 per month for those first 3 months. When you look at the cases closed, if we look at the percentage of all of our eligible VR participants who are on service plans, so this is where I want to make sure that I draw attention to the distinction between this and the next line. So these that are individuals, they've been referred, they've applied, they've been found eligible, and they have an individualized employment plan. And so they're on that service plan and they've been closed, their case has been closed with VR, and they've closed or exited with employment. So for the first 3 months, or the state fiscal year 26 to date, that's slightly over 51%. as compared to the prior state fiscal year at just under 47%. So we're seeing improved outcome there. So we're happy about that. And then the next is, if you look at all closures, you're saying, wait a minute, you just said closures. Not all individuals make it to service plan. So we have individuals that come in, they may be going through the process, and perhaps they find a job on their own, or they decide, or they're not found eligible. So if you look at the total, where we're putting our resources, of all those individuals, year to date, a little more than 42% have closed with employment as compared to just under 37%. So again, as a whole, being more effective and efficient in those processes resulting in an employment outcome. I think the other thing is the cost effectiveness. Look at the annual VR spend per case. So for an entire fiscal year, last year, the average spend per case, per person, was a little over $3,000. Now, you say, well, state fiscal year 26, it says 966. Well, it would be a cumulative cost. So this is quarter to date. We have spent, on average, per participant, $966. So I think an extremely cost-effective service model, moving people to competitive integrated employment. I'd also like to highlight, we talked about our blind and visual impairment services. The next to the bottom line says business enterprise sites operated by blind vendors. So we support Hoosiers with visual impairments and entrepreneurial efforts through our blind vending program. You can see in state fiscal year 25, there were 137 such supported opportunities, and 84% of those were operated by blind vendors. There are at times when other entities are brought in, if there is a, I guess I'm going to say a break, as we identify another Hoosier who may be blind or visually impaired to take on that opportunity. So we don't want to lose the consistency of the service. If you look at state fiscal year 26 thus far, 138 opportunities, and 88% of those are actually operated by blind vendors. And with our deaf and hard of hearing services, you could see our certifications issued. We had 308 for our interpreter services, and we're at 298 during state fiscal year 26 thus far, 12 of those being renewals. Steve?
Okay. Thank you, Kelly. For our financial summary for the Bureau of Rehabilitation Services, as you can see in the year-to-date expenditures portion of the report, we've spent $29 million, just a little over $29 million so far through the month of September, and we had budgeted $30.7 million, so we're not far off of what we had budgeted. The two main areas I'd like to point out, though, is in the far right variance column. Now, that's a variance based on our total anticipated spend for the state fiscal year compared to our total budgeted expenditures for the fiscal year. And there are two areas where we are right now showing that we may not spend or may spend more than what we had budgeted. And the first one is in personal services. That's where a lot of our staff's salary and fringe payroll costs are located. Right now, I am forecasting that we're going to underspend that budget due to having 17 vacancies in the Bureau at this point. That could change depending on some of the hiring and other practices that may impact this as the year goes on. And the other area I'd like to point out is under what's called ID bills or interdepartmental billings. We are overspending on our budget so far, and that is mainly due to what are known as SWICAP expenditures, which has to do with statewide cost allocations, which gets into things like some of your state agencies that serve all other executive agencies. And those costs get allocated out to the various different programs, various different agencies, and we did not anticipate the amount that that was going to cost us. So I just wanted to point those two out. Otherwise, everything else is looking pretty much right on target.
Thank you, Steve. I will also highlight here, throughout this section, I've referenced some of the initiatives that BRS has taken, I think, to be efficient, during the current fiscal waters in which we swim. I would also like to acknowledge kudos again to the team. While not just large sums of money, we have found through some of that allocation process and really kind of drilling down into the budget, we found some additional dollars that we weren't matching or leveraging for federal match with VR. So we are improving our internal processes as well. We're going to move on now to the Bureau of Disability Services, BEADS, as it is lovingly known. We do operate a centralized office here in the Government Center, as well as 8 field offices or district offices throughout the state of Indiana. We are responsible for operating 4 home and community-based Medicaid waiver services, and we'll discuss those as we move through this presentation. Those BEADS personnel serve as the intake and eligibility entity for individuals with intellectual and developmental disabilities, and I'll kind of parse that out as we move through the presentation. We also license provider-owned and operated supervised group living facilities, otherwise referred to as group homes. And we enroll the home and community-based Medicaid waiver services providers. What you see here are the number of participants that are served by county. This is updated to reflect Q1 in state fiscal year 26. Next slide, please. So what you have in front of you are some metrics related to those home and community-based waiver services. I think what I would highlight here, and I'll get to the pie chart after I go through the metrics that are on the right, is that the applications for the Bureau of Disability Services, intellectual and developmental disability services continue to trend up. We continue to see strong demand for that. If you compared Q1 26 to Q1 25, pretty similar. 1,877 for this first quarter as compared to 2,200 in the last state fiscal year. You see numbers for the wait list. We have waiting list for the family support waiver that serves individuals with intellectual and developmental disabilities. We have just under 10,000 individuals on that waiting list. Also, the health and wellness waiver waiting list, we have a little under 4,600 individuals on that waiting list. Across all 4 of the waivers that we operate within the Bureau of Disability Service, so that would be the traumatic brain injury waiver, the health and wellness waiver, family support waiver, and the community integration habilitation waiver, we are serving 47,500 plus individuals. This year, during the first quarter of 26, we've seen just under 1,200 new enrollments across those waivers during this first quarter. We're going to talk about costs on the next slide. You also see some numbers about caseloads for our BEAD service coordinators, and the number of invitations that we have issued, if you will, for particular waivers. So year to date, we've extended almost 2,100 invitations to individuals that were on the health and wellness waiting list, 820 for those that were on the family support waiver waiting list, and our community integration and habilitation, which is our priority emergency needs placement year to date. state fiscal year to date, we've invited 139 individuals to that. And the TBI is a very small waiver, but there have been 3 individuals that have been invited to that. It's also interesting to note, you look at the chart, or the pie chart on the left, looking at the health and wellness, the traumatic brain injury, and then money follows the person for health and wellness, living arrangements of the individuals that are supported by that. Predominantly, those folks live in family homes. You'll see there's a significant number, over 40%. We also have a significant number of individuals that are supported in structured family care or adult family care or foster care. So that's a pretty significant number. It's less than 20% of individuals that are living alone. And we have a small number of individuals, about between 400 and 500, that live in assisted living facilities. Note that this is individuals that are under the age of 60, so 59 and under. Next slide. I'll move through this one pretty quickly, but the OMPP team was referencing this. I'm going to feather in some of our efforts to work within our appropriation and our current fiscal environment and constraining, if you will, Medicaid growth, the spend, if you will. So if you look at the family support waiver, and that's a capped waiver, it's just under $27,000 per year that is the cap on that waiver. We have over 24,000 individuals supported there. There's an authorized budget for individuals, and this state fiscal year, that average is just under $18,000, meaning service plan developed, there's a budget authorized for up to $18,000, close to $18,000 per year. When we look at the spend, and thanks Kathy Leonard for advising as we were working on this, we looked at the entire 12 months of state fiscal year 25, just so that we could use actual claims. The average spend per member per year on that family support waiver when we looked at 25 was just under $14,000. 2/3 of the individuals with intellectual and developmental disabilities are supported on this family support waiver. The companion waiver to that is the community integration and habilitation waiver. That is that emergency placement waiver for priority needs. We serve around 9,200 individuals. When we look at the authorized budget, the average for the current state fiscal year, it's right around $130,000. And when we look at what is spent, and so when we looked at an entire year, that's, again, just under about $114,000 per year per participant. So you can see that's a comprehensive waiver. Those are individuals typically with more complex needs. And I do want to note, this is only waiver cost. So one of our initiatives is we are improving our coordination and collaboration with our partners in OMPP. We are really working with our data and analytics team in order to look at the entire Medicaid spend. And so how do we better support individuals? It's obviously, we are dealing with fiscal matters, but this also is about quality. How do we improve outcomes for individuals? If we have someone that is being supported through a comprehensive waiver, like the CIH waiver, one would anticipate improved coordinated health care and health care outcomes. So how do we do that? How do we do that better? How do we do that more effectively and efficiently? You're also going to see referenced in our initiatives waiver reset. That's something that we are targeting for calendar year 27 that we would roll out as we launch into state fiscal year 28. But as we move toward that, right now we are looking at those community integration habilitation waivers and what we would refer to as kind of those high allocations. Where do we have larger expenditures? So 9,200 individuals are served. We had about 1,200, Holly, that we would say would be kind of a high spend. And so what we are doing is looking at these on an individualized basis. It's not an arbitrary, go in, if you're here, cut there. But is the service plan and the budget based on need? You know, Kathy, I loved the play-along game that OMPP launched with. If we know that our pie or the bucket that we have or the allocation that we have isn't going to grow, or if it does grow, it's just going to be a minimal growth, we want to ensure that we are able to serve the most people in need. And I think we keep leaning into, we have to focus on need. And there are difficult decisions to be made. So we want to ensure, you're going to hear me say, right services, right people at the right time. So are we utilizing the appropriate services to support the identified need? Is the service Medicaid waiver, whether it's through DMHA or through BDS, is that the appropriate service? Is the person functionally eligible, and is this the service that will meet their need? So we want to ensure that we're getting to those individuals identified as appropriately eligible with the need, and then at the right time. The other thing that we are seeing is that we should see some people who come on to waiver and their needs would diminish, and there will be some people that will achieve outcomes, and we can identify typical and natural supports who may no longer need the waiver. And that is something we should all strive to achieve. We also know there are some individuals who always will need some level of support, and we want to continue to monitor that. And then there will be individuals that their support need will increase. But what other resources at a local level, family level exist to support the individual, and where are these state dollars necessary to fill those gaps to ensure the health and safety?
So the other piece about evaluation here is does the claims history, and even better than that would be access to the electronic medical record, so you can get the clinical, so you can get the clinical notes. Does that support the level of care that that
Indeed.
individual is receiving or not? So that's another reason to better coordinate with OMPP on these folks, because I'm not saying they don't, but it's just it's a helpful check.
It's something that we don't know. I also think there's a lot of opportunity. We've done some studies with Inter-I, and Aaron Wright and I were just looking at this, and this was across non-waiver services, across health and wellness and pathways. And I found it interesting in the study group that whether it was non-waiver, choice, those type of things, or waiver, 30% of each of those groups were on 13 plus medications a day. So again, I think to your point, you know, are we effectively coordinating care, managing services? Are we seeing the improved health and wellness outcomes and quality of life for individuals that, you know, that we should be? So we are doing that now. We're working with case managers. This is on an individualized basis. Many of you may have already been involved in this process. And we want to learn from this. It isn't just focused on these 1,200. We should do this across the whole regardless. The service plan should be based on need and filling those, you know, those gaps and utilizing the strengths. So you will see the average authorized budget, if you look at our IDD population, 2/3 family support, 1/3 community integration habilitation, is just under 50,000, 48,000. The spend was around 41,000. So as we move toward waiver reset, when we say that, we're not eliminating waivers, but we will have a new array of waivers. We are going to be leaning into a level of care assessment to ensure that eligibility is appropriate. We want to use that tool for service planning as well as developing a support needs budget. And that array of waivers then will support individuals across the spectrum, those with physical disabilities, those with traumatic brain injury, those with intellectual and developmental disabilities.
So can we talk a little bit about money follows the person?
Yep.
So I've got a couple questions there. So have we
I'm going to
turned,
have her move to a slide. Go ahead.
have we turned back on money follows the person?
We actually just relaunched entries into Money Follows the Person in September. So you'll see here, let me look through, we did include a slide about the enrollments and where we are. We have several, what's not represented here are the number of people kind of in the pipeline that have applied up to this point. With, I think, the awareness that we have made regarding the relaunch of Money Follows the Person, we've heard a lot of some initial feedback from people who are in nursing facilities who are excited about an opportunity or a path to, let's say, assisted living in order for them to be able to come back into the community.
Yes.
So we have restarted or relaunched. Hopefully everybody here knows that we have done that. We've been working with the local AAAs and our local BEADS offices on that application process. So this would be us winding down the MFP budget year in December. It's a calendar year budget. So we'll be soon planning on the next MFP budget submission in early 2026 to determine kind of our slot needs, how many participants we want or think we can shoot for to be funded in MFP in the next calendar year.
So it has been encouraging. I have been receiving emails with people saying they were very happy that their application had been processed for Money Follows the Person. So that was a great question. I also, Kathy, I don't want to steal your thunder, but I've really been talking about initiatives. I think one of the creative things that we were able to do is we utilized, there was a capacity building grant, Money Follows the Person. So it's separate from this because this is actually kind of the programmatic implementation. So we were able to utilize those funds to support some of our expenses in subject matter expertise, if you will, as we move toward waiver reset. So that's 100% federal dollars. And we were able to leverage that and not lean into our state appropriation and redirect those to other services and support areas. So, and that, Kathy had a large part to do with that.
Sorry.
Nope, you were doing great.
I'm trying to scroll back to where
I
we
don't
were.
think we have too much more. I'll hit a
Okay.
few more. Where are we back? Was that? I think that's where we're at.
Did we already do this one?
Is that next?
Level of care.
Go back one.
Go back one.
Go back a little more.
There we go.
Yeah. So the Bureau of Disability Services is responsible, and again, OMPP alluded to this, to overseeing our vendor, our level of care assessment representative vendor. What you see here, some graphics around the level of care determinations. There are two distinct categories. On the left, you will see in-flock nursing facility level of care. So those, again, exactly what it said, nursing facility level of care, the individuals who would be applying for health and wellness or pathways waiver must meet nursing facility level of care. So that's functional eligibility. What you will note in dark blue is the number of, or the percentage of individuals who are found to be functionally eligible. And you will see most of that pie is blue. So 97% year to date have been found eligible. So those who have applied for those waiver services or for those nursing facility level of care services, 97% have been found eligible. On the other side of that, you will see ICF, IID. So those are for individuals with intellectual developmental disabilities. Those level of care determinations are conducted by our BEADS personnel, so our service coordinators and case managers on reassessment. you will see it's basically 100% approval. It's like a small, less than 1% are not found eligible. We have shared with you, we are implementing a new level of care assessment tool. I think this pie speaks to the reason why we are doing that. Our goal is not to deny services or find individuals ineligible, but we know that any system that works appropriately, there should be a higher percentage of individuals found not eligible. So the current tool isn't working as it was intended to, and we don't think that's going to be a huge jump in denial, but we should see, Holly, I'm looking at you, probably 4 to 7% denial rates if you kind of look at national averages and what we know in putting this together. True. And just to give you just some overall numbers, and next time we'll embed these in the pie chart. So this was an oversight on my part, and I apologize. So when you look at the total number of level of care assessments, both categories that have been completed year to date, the first 3 months, it's 27,000, just under 27,500. So that's a significant amount of level of care assessments. Just under 17,000 of those were nursing facility level of care assessments, and just under 11,000 were those ICF IDD. I won't spend a lot of time on this because we already referenced the metrics. You can see individuals on the family support and health and wellness wait list. The family support waiver is continuing to trend up. I will note, and Holly, I'm looking at you, about 80% of the individuals that are on the family support waiver wait list are under the age of 13. Am I misquoting that? Because I'm pulling it from my memory banks. Okay. So 80%. So those individuals who are Medicaid eligible are, they have entitlement services. They're eligible for EPSDT. They also have Department of Education entitlement services. And we do work when they connect to make sure that people are aware of the other services and supports that are available to them. The health and wellness waiver, we've really been keeping that level. I will boast a bit. I think we've improved some of our processes since January of 2025 in reissuing and monitoring waiver invitations and making sure that those just aren't held. Someone's invited and held in an inactive status. So an invitation is issued. The individual has 180 days to accept, get through the Medicaid eligibility process, and move to active status. So that's allowed us to continue then to invite individuals and bring more people onto the health and wellness waiver. And you can see the growth. We're continuing to trend up on the numbers served. You are going to see a drop from March of 25 to September of 25 on health and wellness. And a lot of that is just kind of the reset as the waiver year ends, right? There are enrollments that were inactive, and then we'll reissue. Yes, I'm watching my time back there. So these are metrics on our supervised group living. I'm going to say to you, you will see this in the list of initiatives. One of the things that we are looking at is SGL, or institutional modernization. We're looking at how do we redesign our supervised group living to support the current need. We know that we have a population with more complex needs, particularly behavioral health needs. It is a younger population, a lot of young men, actually, we know it that distinctly, say between 18 and 25, who have some particularly complex, a history of trauma, complex behavioral issues. And our current system doesn't really support that. So looking at how do we move from a system that was designed now, nearly 50 years ago, and modernize that Also, part of that will include the build-out of an additional comprehensive rehabilitation and medical needs facility. Did I get all the letters? CRMNF. So that really is, I refer to it as kind of a step down. It is a more structured environment. There are some, controls. It is a voluntary placement, but it is kind of a step down, a transition, if you will, oftentimes for people that are leaving a state psychiatric hospital. It also can avoid such a placement. Someone that doesn't really need that level, but needs a bit more structure than we can provide in a home and community-based waiver or within some of our other SGLs. You will see, I think the percentage of individuals accepted, so when you look at applications, that second row, we had 72 applications. That's September 25, 25 new enrollments. And the vacancy rate is creeping up. And a lot of that is applicants for those services aren't being accepted and we can't find appropriate placement, which intensifies the need for modernization. So I do want to highlight that. The cost that you see reflected here, the average spend per individual, does not include the CRMNF. That is obviously a higher cost model. There are about 20 individuals that are supported in a CRMNF, so it is a small piece of what we do. But the state fiscal year 26 to date, the average spend per person is about $129,000, $130,000 for our supervised group living. I think we can, I'm going to try to move us through. This is a pie chart that looks at our Medicaid versus non-Medicaid spend, and as you might imagine, the majority of our spend is in Medicaid. And so when you look at that pie chart, you're going to move to the gray, which is the largest area, and that is that comprehensive waiver, the community integration and rehabilitation waiver. 42% of our spend is in that service category. What you note at the bottom of this slide is that's the spend in the pie chart. And then we're going to look at what is the percentage of the whole number of people that we serve. So we serve 9,300 some odd individuals on the CIH waiver for the purposes of this data. And that is reflective of less than 19% of active individuals, and we spend 42% of our dollars there. So that's just indicative of these are the individuals that would be described as having more complex needs. Health and wellness is the next biggest area of spend for us. It's nearly 30% of the total spend. But if you look at the correlation, that's about 26% of the total population. So pretty close. I think the team has done a really great job. Kathy Leonard and the team reflected on, excuse me, I talk with my hands, reflected on the movement with attendant care, and I think we've done a good job in bringing those budgets down. And you're seeing that kind of average cost for health and wellness come down and mirror what we're seeing in that average spend across both family support and community integration waiver. I won't go through each of them. I just wanted to highlight those. Steve, do you want me to talk about this one?
Sure.
Okay. So, again, if you were here earlier for the presentation from OMPP, I believe this was highlighted. This focuses on the waivers that we operate. I think as was noted earlier, across all but one of our waivers, our spend is under the forecast. We're over last year. We're serving more people. We're over last year. And there's some areas of focus for us. But on the family support waiver, we are over forecast. So we are kind of delving into that. There has been some pretty significant growth in the family support waiver, but we just want to ensure that we don't have any anomalies there. And so we are delving into that variance.
Okay, here's the financial summary for the Bureau of Disability Services, or BEADS, as we like to refer to it. So far, up to date through September, we have spent almost $7 million out of a budget of $12.8 million through the month of September. So like the previous two bureaus, we're a little bit underspend on what we've budgeted, but again, we anticipate that that's going to change gradually as the year goes on. And that's why you won't really see much of anything changed in the far right variance column. The only one in which we're showing that we are forecasting underspend on our annual budget is in the personal services, similar to the Bureau of Rehabilitation Services. That's due to vacancies that we have been carrying, and we anticipate that's going to result in an underspend on the overall budget. Otherwise, everything else looks like it's probably on pace to be able to spend what we had budgeted, and it's looking good so far. And this is the DDRS, the entire, all three bureaus, and the administration portion of that, which includes, for example, a couple of the folks sitting to my right, and other people who get paid out of this state funding that we have. This is another one that we don't really see anything that we're concerned about. We anticipate we're going to spend almost all of our budgeted dollars that we have. The one area in which you will find a variance in the far right column is again under the interdepartmental bills. And similar to a previous bureau, that is mainly because of those statewide cost allocation plan expenditures that we incurred earlier last month. Other than that, everything else is on pace.
And just a note here, we are presenting as the Division of Disability, Aging, and Rehabilitative Services, but you will see financial reports for DDRS as well as Division of Aging because the dollars were appropriated in that manner. So, thank you, Steve.
You're welcome.
So now we want to move on. I'm watching my time. We're good. We want to talk about the Bureau of Better Aging and really kind of look at our AAA network overview. If you've attended before, you know that the Bureau of Better Aging is the state unit on aging, and that's under the Older Americans Act. And how we function is we designate area agencies on aging, referred to as AAAs. You'll hear us use that terminology a lot, to assist older adults to live as independently as possible in their communities. And a lot of the funding that we receive, the federal funds, is passed through to the AAAs in order to support these services and information. We also, and Steve will speak to this, utilize some other sources, social services block grant, and some Medicaid dollars and choice funding that is also awarded to the AAAs. So when you look at the whole of aging, the Bureau of Better Aging, about 67% of the Bureau of Better Aging's funding is passed through in either grants or contracts to those AAAs. Steve?
This is a financial summary for the entire Bureau of Aging, Better Aging, I should say. This one breaks down everything by program, which is a little bit different than the previous Bureau's reports that you had seen. Each one of these programs, aging administration, adult guardianship services, adult protective services, choice, and so on, each one of those have their own individual reports as we proceed through the rest of the slides. But just to get a glimpse of the entire program summary for the Bureau, you can see that we've spent $32.9 million out of a $42 million budget. The reason for that variance is because we are a little bit behind and working on catching up with what we're, with the money that's going to the AAAs. And when that money is all in their hands, they're going to be catching up on their claiming and we're going to see a whole different picture over the next quarter. So we, again, anticipate that we're going to end up spending most of these dollars by the time we get through the end of this year. There are some variances in the far right column, but nothing of any major concern at this point.
Okay.
The next one is a look at the Aging Administration Fund. This is a state appropriation that we receive, but also does get some support from Medicaid. We are running vacancies in this particular budget as well, and we are hoping, though, that those are going to be filled in the near future as part of the reorganization. And as a result of that, we're going to be able to take a closer look at where we stand with personal services once all of those positions are filled. And then that's going to probably be reflected in future reports. Otherwise, again, this is another one where everything is pretty much in line with what we had budgeted.
So we want to speak a little of the home and community-based services that are supported through the Bureau. I will note, you'll see some areas, we're not reporting on state fiscal year 26 on some of the choice claims because we're waiting for submission of those from the AAAs. We do fund a range or a variety of home and community-based services through that AAA network, again, utilizing both federal, state, and local resources. That's inclusive of client donations. We directly served over 13,000 individuals in this first quarter of state fiscal year, and over 11,500 individuals received meals, either at home or in a congregate setting. We do note that waiting lists for all these programs have grown over the last year, and we're seeing increased demand as well as, increased utilization of the services that are available. Choice is up, 25%. Our Title III C2, which is home-delivered meals, there's a waiting list for those services. And then our Title IIIE, which is the home direct caregiver supports, if you will, those have more than doubled. I think Title III and the financial, there's nothing really of significance there to report. No big variables. I do want to highlight, because there is a lot of emphasis on nutrition, and I think this is something that is being done well, and we have a lot of opportunity for upside potential. You can see the network of congregate nutrition sites throughout the state. There are 226 of those in total. As I mentioned previously, over 11,000 individuals have received meals during the first quarter. And across the state, we're serving an average of 50,000 meals per month at those congregate meal sites. The majority of the individuals that we're supporting through those home-delivered and congregate meal sites are females over the age of 60 who are low income, live alone, and are at moderate or high nutrition risk. So using statewide needs assessment data that was conducted in late '24, we do know that nearly a quarter of older Hoosiers have at least a minor problem having enough food to eat. So we are really looking at leaning into this in the coming year. Next slide. Want to try? I think, again, this is kind of pretty straight pass through, and you can look at that at your own leisure, if you will. I want to spend a little time here before we move to close, talking about access to service. I talked about the State Unit on Aging. They are the Aging and Disability Resource Centers. They are a primary door, these AAAs, to access those long-term services and supports. Those are housed within the AAAs, and they provide information and assistance as well as Medicaid application assistance. And I will note that we are seeing significant increases compared to the prior fiscal year in the number of individuals who have been supported on the waiting list as well as in Medicaid application assistance. So we've really been leaning into that. So I know I got to wrap it up here. I do want to highlight, though, one of our continued initiatives is looking at House Enrolled Act 1391 as we lean into choice, modernizing the AAA network, supporting them in that process. How do we better support services? And really leaning into how do we focus more of our spend on direct services versus administration. You will see some data that shows that a significant portion of dollars are being spent on administrative overhead, and we want to redirect as much of that as possible to services to address the waiting list and the need. We've talked about money follows the person. Residential care and assistance. We are continuing to lean into this. This is an integral piece of the continuum of services. I do want to note that we support individuals who would otherwise be homeless. A lot of these folks have a history of incarceration. They must be Medicaid eligible. So Steve and the aging team, we are looking at that current rate so that we can sustain that extremely efficient and effective program. It serves a small number of individuals, but we would be working within our current funding model in order to do that.
Right.
And then I want to hit the elder care. Yeah. So finally, as we move to close, I want to talk about how we preserve and protect elder rights. So the Unit on Aging has responsibility in many areas for protection and advocacy. We rolled out a new model for adult protective services just at the start of this fiscal year. You will see the new regionalized map. There are 5 of those areas. We are happy to report that we are seeing improved consistency and approach across those regions. You can see the number of open cases to present and the caseload range per staff member. So that is falling where we want it, between 11 and 20, but we're seeing improved consistency. When we complete the first 6 months of this rollout, we'll have some more specific metrics to share with you. I also want to talk about our long-term care ombudsman program. We give updates on this on an annual basis. This is housed within the Office of General Counsel, but it is funded through the Division of Aging and the Bureau of Better Aging, but really protecting individual rights that are in those long-term care facilities, nursing facilities, and assisted living facilities. I think I will highlight for you, there is a slide with the DDRS initiatives. I believe that I have referenced the majority of those as we've moved through this, but they are there for those of you that would like to access this later. I will note, Kathy Leonard, we are leaning into DSNP, those duals for individuals with intellectual and developmental disabilities. We're actually participating in a project now and working with our medical director, Dr. Stephen Council, to improve that dual enrollment for individuals that are supported through the Bureau of Disability Services. With that, you'll see a list of our contracts. We've leaned into consolidating contracts. We have been able to bring down the cost of some of those contracts and leverage federal funds to reduce the burden on our state appropriation. So you see that for both divisions. And then there are a couple of appendices for small budgets in the aging. One is a closeout. Again, you can reference those. And I think that is it.
Yep.
Okay, we have a couple of questions that came in, one online and one by a note card. From Jim Albaugh, how might the state best capture the potential demand for the CIH Medicaid waiver since there's no waiting list?
Holly, I'm going to look to you if I say anything inappropriate. While there isn't a waiting list, there is an application process. We currently track that. We know the volume of applications. We also know the percentage of approvals and denials for those. That's presented at our DDRS Advisory Council, but I think that gives us a rather good reflection on need.
And second, we understand that the level of care assessments conducted by Maximus will be telephonic unless an in-home assessment is requested by the family. Do you have any concerns that without face-to-face assessments, that LOC approval rates will not actually decline?
Not at the present time. As with anything, when you roll it out, we're going to continue to monitor that. And Holly, I'm looking to you. When we say telephonic, is it telephone or is it a virtual? Okay. I just wanted to make sure. Because I think often a virtual tool is utilized so that there is some visibility. And as you said, an in-person assessment can be utilized when indicated or requested. So I think it's not just upon request. There may be an indication that is necessary.
Okay, thank you. We will now take a short, really short, like 5-minute break. And then afterwards, we will have Secretary Robe's exciting presentation.
Okay. So first of all, I want to talk about some of the near-term effects of the government shutdown. Right? It doesn't appear, I'll admit to you, significant surprise that we're going to go into next week without an ability to pay SNAP benefits. But that appears to be the case. So we are encouraging you as individuals who care deeply about those who are less able than we are to increase your contributions to food banks if you make them, and if you don't, to begin them, right? To give you some sense of the number of people who will be not receiving benefits next week, we spend, and earlier this morning, Sunshine went through these numbers with you, but it's $112 million a month. 250,000 families with an average spend of $414 a month. That's not going to show up on their EBT card on November 5th in our case, and November 3rd in some states' cases. So that's going to cause a real hardship for folks, and I think we need to recognize that problem is a real one. The other issues really won't be impactful unless this persists sometime into next calendar year, which we are hopeful it will not be the case. Candidly, I can't believe it would be. You guys have seen this slide before. It's the way I kind of think about the Medicaid program. Hoosier Health-wise and Hoosier Care Connect, as I think Kathy referenced, pretty good. Kathy referenced it. There you are. Kathy referenced pretty good deal, really. $460 per month, right? If you go on the exchange and buy it, you can't buy it anywhere near for that price, right? The Healthy Indiana plan, again, not really that bad a price, $883. Again, on the exchange, you can't buy it for that price. But over here in fee-for-service and pathways, this is where the growth has happened, right? We've gone over a decade, we've gone from $4.2 billion to about $11.3 billion. This is the folks we were just talking about. This is the disabled population, some of the mentally ill population, a very expensive group, and that we have to try to figure out how to constrict the cost growth trajectory. And the reason, and again, most of you have seen this chart before, but again, I want to indelibly burn this into your memory. In 2017, we were spending $2.1 billion in general revenue fund. By the end of this biennium, we'll be spending about $5 billion. That is a 134% increase over that period of time, 9.5% compounded average growth rate. The general revenue fund is not growing that fast. So the fact of the matter is that the Indiana Medicaid program is taking an increasing chunk out of the general revenue fund, ultimately leaving less for conservation, for higher ed, for K through 12, for other services funded by the general revenue fund. So it is incumbent on all of us to figure out different mechanisms for providing care. I'm not going to really focus very long on this. This is the ABA issue, right? We all know what the ABA issue is. We know where we are. We have to get to a different place. We've got a report that will be coming out shortly once the governor has had an opportunity to review it, and we'll make some changes. But ultimately, that number is not going to go. That number will not go down, right? That number will stay, relatively speaking, where it is. We've done a better job on the attendant care issue, but we still have a very high attendant care budget that Kathy went through earlier today. And then this one, this is the new one, and you guys haven't seen this before. And this is federally qualified health centers, 2025 PPS rates, right? The red line, if you walked into a healthcare provider in Fishers, Indiana, or in South Bend, Indiana, just a general primary care physician, we would pay them, or more accurately, the health plans would pay them approximately $99. So while it looks like that's at 100, Kathy assures me it's at 99, and she's an actuary. And this is what we're paying on a per visit basis for federally qualified health centers. We are paying as much as over $600 per visit for federally qualified health centers. Not everybody gets their health care at a federally qualified health center, but this is an area in which we can't abide this kind of cost growth. So we're going to be working with the association to lower that cost. We appreciate the difficulties of being a federally qualified health center, but that delta seems to me to be a bit greater. In addition to that, I'm not sure it's equitable that Shalom Health Center is receiving less than $200 and Meridian Health Services is receiving over $6. Again, many of our services don't have particular metrics. We're getting better at that, but we need to improve and continue to work on our metrics. Let me just talk a little bit about where we're going with the Healthy Indiana Plan. We're going to have a work requirement. I think I mentioned last time we're going to have that work requirement. We had hoped to start 7/1/26. The federal government said they won't be ready by then, so 1/1/27 it is. That's when we'll have work requirements. We are going to do our very best to revise a benefit package that puts personal responsibility back into the Healthy Indiana Plan. That is the way it was designed by Governor Daniels. It was the way it was approved by the legislature, again by Governor Pence, again by Governor Holcomb, bipartisan support in the legislature, ended by one man in Washington, D.C. So we are going to try to get CMS to give us the opportunity to remake the HIP program, or as my wife likes to say, Indiana needs a new HIP. Rural health, this is upcoming. We'll be submitting this on Monday or Tuesday of next week. Many of you in the room, I hope, have been involved in the development of those recommendations, and we're excited about that prospect. But it's only going to be for 5 years, right? It's only going to be for 5 years. We are not going to put someone like Adam again through what he's going through, trying to manage the child care cliff. For those of you who were here this morning, that child care cliff is very difficult for families. It's very difficult for providers. And it's very difficult to administer. So our program is going to be about infrastructure, not about creating a cliff that we can't afford. Because most of us are aware that the out years in the Medicaid budget become more difficult. You guys think this year is difficult. Well, when the 6% fee that we get that we use now for the hospital assessment fee drops down to 3.5%, we lose hundreds of millions of dollars out of the Indiana Medicaid program, which is probably likely to grow between now and then, at least a little bit. So it's going to be a difficult task. I'm not going to spend a lot of time on this. 20 years ago, I used to say, when I was here, we were buying a Cadillac and getting a Chevrolet. Okay, Chevy's not a bad car. Today, we're buying a Cadillac, and I don't know what that is, but we're getting, but we have some of the highest healthcare prices and some of the lowest health outcomes in the country, and we need to do a better. We can do better than that. 20 years ago, we went to the hospitals. We went to the hospitals 20 years ago, and we said, please lower your rate. We'd be appreciative of you lowering your rates. They said you have too many uninsured people. So Governor Daniels and the bipartisan group created the Healthy Indiana Plan. That was HIP 1.0. Then my understanding is the Hospital Association worked with Governor Pence to add, to do HIP 2.0 and increase a hospital assessment fee. That hospital assessment fee put 750,000 more Hoosiers under insurance at a cost of about $7.5 billion. Yet our healthcare costs have not decreased. So as you probably have read by now, we are leveraging Medicaid reimbursement as a strategic tool to incentivize hospitals to lower their average commercial rate. This is an ongoing conversation that we have with the hospitals. They are not in complete agreement with our methodology, but we'll continue to work through that. So here's the piece that I want you really to take away, particularly if you're not well, even if you are a hospital. This is the last buffalo hunt, right? We're going to Washington, D.C. The governor and I go to Washington, D.C., and we're going to ask CMS for dollars. And those dollars, we are hopeful, will be more than what we're getting today, right? We're excited about the opportunity. We think we've created a really good product for CMS. But what CMS has said is, what you get is what you get. They're going to take our program, they're going to put it in a box, put the box in the freezer, and lock the freezer. That's all we're going to get. The Trump administration and the Republicans have been very clear that no mas. So we got to live within our means. And this comes to the 2% slide. So again, let me show you how the Medicaid budget has been traditionally built in Indiana. It's been built doing the following things. Healthy Indiana Plan. Let's see. How many members do you have? What's the per member per month rate? Times 12. That turned out in 2023 to be $6.3 billion. Who's your Care Connect? How many members do you have? What's the per member per month? Times 12. That turned out to be 1.5. Who's your HealthWise? Help me here. How many members do you have? What's the per member per month? Times 12. 2.2 billion, so forth. I won't do it again. If you didn't get it by now, that adds up to $17.9 billion. Okay, that's a lot of money. That's the uses of cash that we have for Indiana Medicaid. Now, what are the sources? Well, we're going to get $13.4 billion from the United States federal government. Of course, that's free money, not taxpayer money. Then we're going to get money from provider taxes. We're going to get HAF funding. We're going to get HIP funding, right? And that's going to add up to $15.2 billion. Now, again, Kathy wanted to know how many math people were in the room, but I don't think you have to be a math person to figure out that $17.8 billion is a bunch more than $15.2 billion. Okay, so what do? Well, we walk over across the street and we tell the governor, the budget agency, the House Ways and Means Committee, and the Appropriations Committee, hey, ladies and gentlemen, we need $2.9 billion from you to balance the Indiana Medicaid program. And because it's entitlement, they give it to us. They don't give it to schools. They don't give it to the Department of Conservation. They don't give it to the Department of Corrections. They fill our bucket first. Because frankly, they have no choice. We're going to build that budget differently in the next biennium. We're going to say we're going to solve for 2%. And 2% is the approximate growth rate of the general revenue fund. And then we're going to work back up that chart until we figure out how to stay at 2%. So that I think if you didn't hear me before, you've heard me today. The goal is to get the state appropriation to no more than 2% or whatever the general revenue fund is growing at. So we can fund schools so we can fund the Department of Corrections, so we can fund the other things that are funded by the general revenue fund. Before I take questions, I want to do a couple thank yous. First of all, thank you to our staff who put all this together today, right? And who put it together every month. Really, you guys don't get to see it every month. I know that's it's horribly disappointing for you. And thank you to all of you who came, and for those of you who listened online. For those of you who listened online, there are empty seats in the room, and you're welcome to attend. I believe it's January 30th is our next, when we will be next together. And lastly, I want to thank the two ladies who got a lot of exercise today, right, for your terrific service that you have given today. So with that, I'll answer questions on the off chance you have some.
If you have a question, just raise your hand and I can give you the microphone. Okay, we got two questions submitted by someone that had to leave early. First, it counts. First, what is an FQHC?
The Federally Qualified Health Center.
And second, is the red line on the FQHC slide representative of the average cost of a visit to a primary care provider?
What we pay.
Oh, one question over here.
So I couldn't help but notice when you talked about the 2% and we're talking about the general fund growth, you mentioned that if the general fund grew by more than 2%, that could potentially mean more funding for Medicaid. Is that what you intended to say?
Yeah. I mean, I'm not looking to decrease the percentage of our current take. Our current take is our current take. I just don't think I don't think we can afford as a state to increase that take beyond the percentage that we're currently taking.
Thank you.
Okay, I don't see any other hands. Thank you very much. Oh, one more. Oh, sorry.
If this
Sorry,
were an
it
auction,
takes-
you'd win.
Yeah, that's what I was counting on. I was just thinking about what you were saying about the 2% also. I've only been in the state of Indiana for 12 years now, but in the time I've been here, the population seems, at least in Marion County, to have really grown. Do you see this kind of serving Hoosiers changing or having more resources as our population goes up?
So actually, the population of Marion County has declined over that period of time. The population of the region as a whole has grown. So if you look at Hamilton County and what are referred to as the Donuts counties, that's grown. But and so the region as a whole has grown, and luckily the state of Indiana is growing. People are recognizing it as a good place to do business, and we do have some in-migration, and that's a positive. We want that to happen, and that's as we would want it. There was actually a point I was going to make here. Let's see if I can remember it. One more time on your, just, Yeah. All right, so that's a great, so the question is, what's the care model? So we have a care model, okay? So I was in Richmond, where was I? I was in Richmond, Indiana yesterday, right? Visiting the state hospital in Richmond, Indiana. The care model in Richmond, Indiana, in 95 years ago, Richmond, Indiana, the state hospital had 1,500 residents. Today we have 200. Because we treat mental illness differently, right? We have a different care model for treating mental illness than we did 95 years ago, or probably even 50 years ago, right? We have far more pharmaceutical therapies available today. We have a different care model than we did in that space. In the world of the developmentally disabled, we used to take the developmentally disabled, and we said to the developmentally disabled, we said to their parents, well, your child is just developmentally disabled. We'll take that child away, and we'll put that child down in Muscatatuck, and you know, you can visit if you want, but that's what we'll do, right? Well, we don't do that anymore. In fact, thanks to the INARF and the ARC, we were able, my first tour of duty, we were able to close the Fort Wayne Development Center and create a different care model, a less expensive care model that was able to care for people who were coming off the wait list. That's an artifact of the past, but it's a different care model. So what we cannot prospectively as a country afford the clinical care model we have today, nor can we afford the home and community-based care model we have today. We have got to find ways to change that care model. The care model we have today was not always the care model. We have to recognize that we made this care model up. We can change it. We can make up a new care model, and fiscally, we don't have any choice but to do that. Is that helpful? Okay. The question is, I think, is it influenced by population growth? The population growth is fairly slow as a state, right? It's maybe, I'm guessing 1% a year if we're lucky, right? So we're not losing population like Illinois is, but it's not going to be, it's not a major driver. Yes, ma'am. This is what we pay to a doctor in Fishers or a doctor in South Bend, Indiana. This is what we pay. I'm going to find the one that. So Raphael Health Center at the corner of 34th and Meridian, pardon me, Central. That's what we pay. That's what we pay. That's what they claim their costs are. Right. Right. But, I mean, if I told you my cost, what's your cost? I mean, here's what we used to do in up until fairly recently, what we used to do in ABA therapy. We paid 40% of billed charges, which is, we said you get the bill, what's billed charges are $1,000. Here's $400. Next month, billed charges $2,000. Okay, here's $800, right? Apparently there's no limit to what you can say your costs are. And this is just one example of a look, I used to run Health and Hospital Corporation, right? Marion County Hospital, which was then Wishard. At the time, we entitled institutions to money because we didn't have Obamacare, we didn't have HIP, right? What we said was, if you got a Medicaid claim, you're likely to have a high uninsured claim. Certainly that was the case at Wishard, right? It was a case at what we used to be Methodist downtown. So we said, well, if you have a disproportionate share of your funding comes from Medicaid, you're likely to have a very high uninsured rate, and so we'll give you this chunk of money. I mean, I used to come over here and Pat Nolting would write me a check for $45 million. Who knows Pat Nolting? Anybody? Hey, all right. Pat Nolting lives. Okay. All right. And at the time, this model made sense because we didn't have near universal health care coverage. But we have near universal health care coverage today. And we're still doing cost-based reimbursement. This model is an artifact of a pre-Obamacare, pre-HIP world, as is DISH.
With the low reimbursement rate, there is, when you look at that difference in cost, there's a difference when you've got providers who don't have the capacity to serve the population, and they stop serving, which increase the cost to other providers who are absorbing that population. So I just.
Yeah, you're far more optimistic about this than I am, right? I mean, I think that if you look at what Community Health System did, they decided that they weren't going to have a Medicaid population and put everything over to what is it? What's that woman who's Jane Pauley? They put everything over to Jane Pauley, and they get paid a lot more at Jane Pauley than they would have there. So. We went, first time I was here, we had 4 community mental health, or rather 4 FQACs. Today we have 500 some odd. I don't think it's because, I think that has more to do with the reimbursement methodology than a need, particularly since we gave 700, in the interim, 750,000 uninsured people got insurance. Yeah, I mean, this line, that's what the Indiana taxpayer can afford. That's what the federal taxpayer can afford. Well, you have to get a different care model then. You have to figure out a way to do it cheaper because there's no money left. I mean, the answer can't be, it costs me more. Anything else? Yes, ma'am.
Back in the day, I could pay average rate now because our average psychiatrist 70. I had to pay a psychiatrist services and that cost. So that has shifted since the last time you were here. Our salary and benefits over the past 4 years have gone up.
Yeah, and I don't disagree. I understand that, and I can't do anything. And you've got to create a different care model, right? You got to find a way to treat that patient in a mechanism that is less expensive. I don't know what that is, right? If I knew, I would tell you, right? I'm not, as I told you before when we had this similar conversation. I do not have a book in my office Zoe, I'm not telling you. A folder. I don't have a folder in my office, Zoe, and I'm refusing to tell you. I'm just going to make you figure it out. But I mean, we do not have the money, and we will not have the money. So go to the Starbucks, smell the coffee. That's the way it is. Hey, on that happy note, thank you very much. For those of you who I see regularly, I look forward to seeing you again. For those who I only see this time of year, I'll say Happy New Year for the first time.